Baik, selamat pagi. Assalamualaikum warahmatullahi wabarakatuh. Sebelum kita mulai kegiatan seminar pada pagi hari ini, silakan untuk para peserta bisa membaca kembali tata tertib seminar online, di mana peserta wajib menggunakan nama asli sesuai dengan nama yang telah didaftarkan untuk memudahkan verifikasi saat diskusi dan presensi. Dengan format nama, spasi, instansi, atau asal sekolah. Kemudian saat nanti teman-teman ingin mengajukan pertanyaan, silahkan tuliskan dengan nama, spasi instansi, dan juga spasi pertanyaan, dan pertanyaan ditujukan untuk siapa. The rules of conference. Participants should join in Zoom on 30 minutes before the conference begins. Participants use real name to easier verification. Participants, please turn on the video and turn off sound during the conference. Please rename with the format name underscore institution, and then list of attendees will be given by link in the middle of event. Evaluation form will be shared on 30 minutes before the seminar finish, and then webinar certificate will be given if the participant fill the link registered, absent, and evaluation by email. It will be given during 14 days after conference. The 4th International Conference on Health Practice and Research, Prevention, Detection, and Treatment of Cardiovascular Disorder will be the main event for today. We are so pleased to have all of you here. The session will begin shortly. Thank you. Well, ladies and gentlemen, may I have your attention, please? Our session is about to begin. Please have a nice seat. Thank you. Good morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Welcome to the 4th International Conference on Health Practice and Research, Prevention, Detection, and Treatment of Cardiovascular Disorder. First of all, let's express our gratitude to God, who has been giving us guidance, happiness, health, and mercy, so we might attend and participate in this event without any obstacle. I am Linda Kusuma, your host for today. I would like to greet our distinguished speaker from Trinity University of Asia, Hung Kuang University, Taiwan, UITM Mara, Malaysia, Emilio Aguinaldo College, our invited speaker from Stikes Telogorejo Semarang, and our moderator. Head of Semarang City Health Office, Head of Stikes Telogorejo Semarang and the staff, and also all participants today. Ladies and gentlemen, please allow me to read the agenda for today. The first agenda is the opening session, and the second agenda is conference session led by our moderator. Ladies and gentlemen, we are now in the opening session. Let's open this event by praying according to our beliefs. Finish. Ladies and gentlemen, we are now in the opening session. We will listen to the song Indonesia Raya. And without further ado, I would like to welcome Dr. Swani Trikayanti, Magister Kesehatan PhD, Head of Stikes Telogorejo Semarang, to give the opening speech. Good morning, Dr. Swani. Time is yours.
Thank you, Linda. Good morning, ladies and gentlemen. Warm greetings for the day. How are you all doing? Let us be grateful for God's love for us today. I, Dr. Swani Trikayanti Widiatmaja, as Chief of Stikes Telogorejo Semarang, welcome you all to the 4th International Conference on Health Practice and Research at Stikes Telogorejo Semarang. Firstly, I would like to thank the experts for taking their precious time and making to this event. And secondly, I would want to thank my audience for being present here today. About 700 audience. Thank you so much. And we have for oral presentation about 20. Thank you so much. Before we begin with our today's session, please allow me to deliver a short speech in order to warm up everyone regarding today's to be discussed key issues. One of the today's major topics of concern, ladies and gentlemen, is prevention, detection, and treatment cardiovascular disorders. I'm sure our experts must have done their bit of studying around the topic, and so our audience. This is a topic that each one of us can relate with, particularly the working class. As all of you know, cardiovascular cases increased every year. Cardiovascular disorders are one of the most caused deaths in Indonesia. Cardiovascular occurred because of some factors such as lifestyle, smoking, and unhealthy food. These factors cause sudden cardiac death. As health professionals, we should promote the preventive, promotive, and curative treatment to decrease sudden cardiac death and cardiovascular disorders. Now, I would like to invite our honorable guests on stage and would request them to share their knowledge with us. I would really help us delve deeper into the subject and understand its nuances. I would also request my audience to remain seated and listen to our experts, as thereafter they shall be able to raise their doubts and questions. These doubts and questions then will be taken up by our panel of experts. In this occasion, I would say thank you to our guest speaker, Dr. Muhammad Abdul Hakam, SPPD, from Dinas Kesehatan Kota Semarang, Mr. Derek S. Wengwa, RPH from Trinity University of Asia, Philippines, Professor Xie Mingxin from Hung Kuang University, Taiwan, Mr. Asran bin Ahmad from University Teknologi Mara, UITM, Malaysia, Dr. Marilu Pamintun from Emilio Equinaldo College, Filipina. And my warm regards to our lecturer as speaker in this conference, Miyanti Nuriski Sutejo, Swiss MPH, Mr. Nurse Kristianto Dwi Nugroho, Nurse Reza Nirmala Jona, Apotheker Francisca Gloria M.Farm, Komaria SSC MKes, Thank you so much for everyone to be our speaker and to be our audience. Hope you all enjoy this session. Thank you.
Ladies and gentlemen, now we have come to our main agenda, the conference session. All presentation and discussion in the section 1 will be moderated by Ms. Made. But before of that, allow me to read her short bio. Okay. Yeah, as you can see, her name is Nurse Nimade Ayu Wulansari, Magister Keperawatan. She graduated in master degree in Pajajaran University. She has participated in many seminars and workshops, as you can see, and she also has so many experience and workshop. And sorry, she also has so many experience. For example, a writer on a book, Pengalaman Hidup Survivor Gempa Bumi di Lombok. Now she worked at Stikas Logerjo since 2016 until now. Ladies and gentlemen, let us welcome our moderator, Ms. Made. And the next session is fully moderated by Ms. Made for approximately 2 hours. I personally believe that we will have a very interesting discussion today. So welcome, Ms. Made. How are you today?
Hi, Miss Linda.
Fine.
Oh, good. So now the time is yours. Thank you.
Thank you, Miss Linda. Good morning, everyone. Morning. Okay, today in this special occasion, I would like to be a moderator for the first session. My name is Nimade Ayu Lansari, and we have 5th speaker in this session. I will explain you about the rules of this discussion. The speaker has 15 minutes to explain about the presentation, and after panel of the speaker, we have a discussion. We have 40 minutes to discussion. So for the all participant here, you can raise your hand in Zoom to ask the speaker. Okay, before I begin to this discussion, I would like to greet the speaker. Good morning, Dr. Hakam.
Morning.
Good
Miss
morning.
Made.
Yeah, I'm sorry, I cannot hear you, Doctor. Yeah, okay. Good morning, Doctor.
Good morning.
Okay.
Miss
For this
Nimade.
session, you will be in the first speaker.
Okay.
Before we begin, I would like to explain your curriculum vitae first, Doctor. Dr. Muhammad Abdul Hakam, spesialis penyakit dalam Vinasim, was graduate from medical school for the Bachelor Medical School from University Sultan Agung Semarang, and for the specialist is from University Diponegoro Semarang. And for the experience in your position, Mr. Hakam as a vice of Director Services in RSUD KRMT Wongsonegoro Semarang. And until now, he is a head of health department Semarang City. Okay, Dr. Hakam, have you ready to present your presentation?
Okay.
You have 15 minutes.
Okay. Thanks to Miss Made. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone, which we respect and proud of the speaker, the second chief of speakers, my best friend, and then respect and our proud of the speaker. The first is of Mr. Derek, and then Professor Singming Sin, Mr. Asran, and Dr. Marilu Marasika, and speaker from stickers, and then ladies and gentlemen, the first we have materi called vulnerable cardiovascular disease in Semarang City. Outlines the first morbidity of cardiovascular case, and then the second health transformation in Semarang City related to cardiovascular case services. WHO journal, cardiovascular disease are the leading cause of death globally, taking an estimated 17.9 million lives each year. More than 4 out of 5 cardiovascular deaths are due to heart attack and strokes, and 1/3 of these deaths occur premature in people under 70 years of age. And then mortality due to non-communicable disease in Semarang City. In 2021, in blue line, and then 2022 red line. So cardiovascular disease very high. Number one, stroke, and then hypertension, diabetes, and then chronic renal disease, and then infarct myocard, decompensatio cordis, and distribution for non-communicable disease. 15 to 65 year, very high. And then in 2022 we have same problem in the 15 to 65 year to be high. Men very high amount to men in very high. And then in next slide, cardiovascular disease in Semarang City 2022, we have 40.1% for congestive heart failure, and then stroke 28.9%, chronic ischemic heart disease 24.9%, and then any acute myocardial infarct, and then another acute ischemic heart disease. Total case of cardiovascular 26.441. And then we have C. You can see new case in blue, and then all case zero. We for problem cardiovascular in Semarang to be high. And then we you can see in the right area, you can see district in Semarang city, any red area from north of Semarang, Kemijen, district of Kemijen, and then Turungan, subdistrict Penggarut Kidul, kemudian subdistrict di Tlogomulyo, red area, and then district Banyumane ada any subdistrict Serondol Wetan. The number of cardiovascular case in January 2023, the Concordes 14, acute myocardial infarct, any active case, and then stroke 52 case. The compensation cortes, we you can see trend of the compensation cortes case from 2020 and up to 2023. Blue line 2020, and then yellow line 2021, and then red line 2022, and then in 2023 green line, this one. And then distribution of the compensation orders in 2023, any region in Semarang City, district of Ngalian, subdistrict on Beringin, more than case in Beringin subdistrict. And the number of case, the compensation code is based on age 2023, age 46 up to 65 pre-elderly, more than case compensation cordis, any sick case, and then more than 65 or elderly category 5 case. We have trend of acute myocardial infarct case from 2020 and then 2023. This area, yes, district Alian, district Gunung Pati, still Gunung Pati, Patemon, and then Banyumane district, Kayamsari, Peturungan, more than Peturungan district, subdistrict Peturungan, Muktiarso Kidul. And then same 46 up to 65, 3 case. And then men more than height to woman. And then stroke case trend 2022 very high to be 2021 and then 2022 2020 very high. We woman very high to be men to 20x 20x case, and then distribution of stroke case in 2023. District of North Semarang, actually in Kemijen subdistrict Kemijen, and then subdistrict Bengawan Kidul, very high case in Kota Semarang. And then we have how transformation in Semarang city related to cardiovascular case services. Ministry of Health many have 6 pillar. Thus, the first transformasi layanan primary services, and then now second hospital transformation, and then 3 transformasi sistem ketahanan, and then 4 pembiayaan, 5 sumber daya kesehatan, and then 6 AD. In Semarang City, we have 32 hospital, map of flagship services hospital in Semarang City, in Gajah Mungkur district Gajah Mungkur, very high hospital. And then Semarang Tengah, very high hospital, and then south of Semarang, very big hospital. Cardiovascular services, stroke services, we didn't have complete services. Stroke services, we didn't. To cardiovascular services, any sick hospital, Rumah Sakit Dr. Karyadi, Tugurejo Hospital, KRMT Wongsonegoro Hospital, Elizabeth Hospital, Telogorejo Hospital, and then Sultan Agung Hospital. To cardiovascular, Karyadi Hospital, only primary, stroke primary. Tugu, intermediate, stroke basic. KRMT, intermediate, to stroke to intermediate. Elizabeth, intermediate, and then stroke basic services. Telogorejo Hospital for cardiovascular primary, for stroke basic, and then Sultan Agung for cardiovascular primary, and then stroke non-category. We can, we need the sick hospital to be complete to services cardiovascular, and then stroke to be complete services. And then in promotive preventive, we have Lawang Sewu, layanan warga Semarang sehat setiap waktu. Any 5 cluster activity, physical activity, and then invite health. The number 3, food healthy. Number 4, screening, and then number 5, education. Each other any activity. Yes, Palas, Prambanan in environment health, any ucok papa, polke, si kempling, for the health, any langit Semarang, Ungaran, and screening, any Baitu Salam, Demak, dan and also. And then we have promotive and preventive effort, FALAS, virtual activity link Semarang Sehat dengan with application. Trade of non-communicable disease is to decrease diabetes, decrease hypertension, engaging in physical activity at least 30 minutes per day, or 3, 5 until 5 times a week. And then virtual activity link Semarang Sehat, the application, the implementation of Kermas, Healthy Lifestyle Movement, in the health office is a program that is carried out by all employees of the health office and its service unit by utilizing of health measurement application on their mobile phone to measure their step and physical activity time. And then transformation of early detection services for non-communicable disease in Semarang City before 2022, yeah, 2022, and then 2023 edition for heart attack detection and stroke detection screening. Will be blood pressure check to hypertension, and then to detect early detection for heart attack, make electrocardiogram, and then stroke, we make laboratorium triglyceride and cholesterol. Thank you for everything. Assalamualaikum warahmatullahi wabarakatuh.
Okay, because you are as our keynote speaker, and for keynote speaker, there is no discussion. Dr. Hakam?
Thank you.
Yes. So if you have a really important event, you can leave this Zoom, Mr. Hakam. Yes, thank you so much. It's really a big occasion for us. Your presentation is really good for us, and it really enlarged our knowledge. Thank you, Dr. Hakam.
You're welcome.
Okay, we are going to our 4 speakers. I will greet for our speaker. Good morning, Mr. Derek. Good morning, Mr. Derek.
Morning.
Yes.
Good morning,
Do
ma'am.
you hear my voice clearly?
Very clearly, ma'am.
Okay. I haven't seen you.
No.
Okay.
Hi.
Hi. I already seen you there. Good
Hello there.
morning.
Morning,
Yeah.
ma'am. Morning,
Okay.
everyone.
Okay, before we begin our session, especially for your presentation, I would like to explain your curriculum vitae. Mr. Derek S. Fengua, PH, is to belong in a institution institution that allow me to fully express that better his technical skill and clinical knowledge in the pharmaceutical field with a working environment that upholds to the utmost standards of integrity and professionalism and is conducive to his development as a human being and pharmacist. Academic background, 2011 until 2016, BS Pharmacy major in clinical pharmacies in University of Santo Tomas Espano, Manila. Next. For board exam rating at March 9 to 10, 2017, score 92.38%. Board top notcher, 9th place. Wow, amazing. And for the affiliation with school organization with held position, 2015 until 2016 in USD Clinical Pharmacy Society as a logistic committee head, pediatric care clinic senior preceptor. And for the pharmacy experience as a majorship in pharmacy in University of Santo Tomas Hospital, España, Manila, June to August 2016, for 360 hours. And for the industrial pharmacies, Medicamenta in 40 Marinano in the Quinzo City, March to April 2014, 200 hours. Next. For the seminar at training, there are a lot of seminar at training that you attended, such as TUA Philosophy and TUA Learning Cloud, TLC, training as a part of the Trinity in-house teacher formation training, T3, year 3 with the theme transitioning to hybrid and high flag, learning, preparing, and navigating the turn of face-to-face learning with online pedagogies and technologies via Zoom, August 70 at 2022. Next, there are a lot of that you attended. And for the research presentations, you are joined in oral presentations, implementing rules and regulation in a drug information center, bridging gaps, pharmacist intervention toward effective dissemination of drug information in current clinical pharmacist practice, the Clinical Pharmacy Caucus 2016, University of Santo Tomas, Manila, April 29, 2016. And also you attended in poster presentations. In the determination of the antidepressant effect of mirtazapine augmented with caffeine using Swiss albino mice, Asian Federation of Medical Science Conference in Bangkok, Thailand, November 29 to 27. Next. And for the community development activities, for the phase 1, patient profiling and community assessment, USD CPS Pediatric Care Clinic, Kaluang Magallanes, Cavite at November 14, 2015. And for the core competition, you are fluently in English and Filipino, both verbal and written, certification in basic life support, proficiency in patient counseling and vital signs measurement, competent animal handling techniques, adept technical writing skills, competent manufacturing instrumentation techniques, proficiency in pharmacology and related matters, willing to undergo additional training. Okay, Mr. Derek, do you still hear me?
No, ma'am. Yes, ma'am.
Okay, you have 15 minutes to explain your presentations. We are
Okay,
a
ma'am.
panel. So after all the speaker explain the presentation, we will have a discussion. Time is yours.
Okay, ma'am. So Good morning, everyone. So this is my presentation for, I was assigned the topic of pharmacotherapy of cardiovascular diseases. And I was also informed, good morning, everyone. First of all, good morning, everyone, to the students and administrators of Telogoregio Semarang Health College. It is an honor to be invited here. And it's actually my first time in this type of environment, in this type of engagement internationally. And it's a huge honor for me to have this opportunity with you, with everyone. Okay, and I was asked to present my topic for 15 minutes, so I'll be doing so. My topic is actually is presented here in your screen. Presented here in on your screen. This is actually a very broad and vast. No, it has a vast scope. And of course, I don't know, given the limited time, I'll just be summarizing and not going through all my slides because this is a lot of slides here. Okay, so everyone, I'm going to assume that some of you, given that you have a certain background, a certain knowledge regarding cardiovascular diseases and certain drugs that acts on your cardiovascular diseases. So technically, to summarize everything, these are your general cardiovascular diseases. You have your hypertension, you have your ischemic heart disease, cardiac arrhythmia, and your heart failure. So for hypertension, this is the elevation of your blood pressure. For ischemic heart disease, this is any disease that's related to the narrowing or obstruction of coronary arteries. Cardiac arrhythmia is the irregular heart rhythm. Is the induction of irregular heart rhythm or having an irregular sinus rhythm in your heart. No, so heart failure is as discussed a while ago, can be stable or decompensated. No, so decompensated meaning the heart is failing to meet the requirements to pump enough blood, okay, to meet the requirements of your body. So that's the basic outline there. And then under those topics, you have the different types of diseases that is under those particular topic. And then you have other comorbidities and other sort of problems that are under these particular topics. So for example, in your ischemic heart disease, you have topics such as your chronic stable angina, okay, angina pectoris, you have your unstable angina, you have your acute coronary syndrome, you have your non-ST elevated myocardial infarction, you have your ST elevated myocardial infarction. For heart failure, you have your stable heart failure, and then also you have your acutely decompensated heart failure. In these diseases, you either have, you can always think of it as there is an acute manifestation and a chronic manifestation. When you say acute, that is some sort of an emergency that has to be treated. When you say chronic, that is something that has to be maintained by lifestyle modifications, and of course, lifestyle modifications, diet, and of course, maintenance medications. So you have to just give you an overview of the drugs. So your hypertension is either, so this is an increase in blood pressure and a comorbidity and a major risk factor in your other types of cardiovascular diseases like your myocardial infarction, also known as heart attack, and your heart failure. So you have, with this, it's either primary or secondary. You have primary, or when you say primary, it's idiopathic, meaning it has an unknown origin. So this one is very, very common, okay? Very, very common. And this one is some sort of, can be rooted in genetics or your family history. Here, your secondary hypertension is just a secondary hypertension means there's another cause for the elevation of blood pressure for the hypertension. So that may be listed here. Some of them may be pheochromocytoma, which is some sort of tumor in your adrenal gland, narrowing of your aorta, which is a congenital disease. And then you have your some sort of adrenal cortical tumors. So of course, tumors there in your adrenal glands, of course, can lead to elevation of catecholamines. These catecholamines can cause various effects, systemic effects, like your vasoconstriction, that will eventually lead to the elevation of blood pressure. So you have compensatory mechanisms like your renin, angiotensin, aldosterone system. If you have for the pharmacists there, or I think for even other health colleges, you have some sort of subject in pharmacology. So this type of topics will be discussed there. So RAAS, we call it here in the Philippines, we just name it as RAAS. Renin, angiotensin, aldosterone. You see here, angiotensin, aldosterone. They play a major factor or in elevating your blood pressure. Okay, and then of course, the inhibition of this system will lead to the lowering of your blood pressure. And then when lowering blood pressure, when treating hypertension, it's a matter using drugs, using pharmacotherapy. It's a matter of lowering blood pressure using different mechanisms of the drugs. And then you have certain drugs like, for example, you have, what type of drugs do you have? Like ACE inhibitors, your angiotensin converting enzyme inhibitors, your angiotensin receptor blockers. Those type of drugs will prevent the effect of angiotensin. So of course, you have your ACE right here. You have your renin. So you have a drug called aliskiren, will inhibit your renin, okay, which will prevent the progression of the production of aldosterone, release of norepinephrine, and of course, your vasoconstriction. And all of these effects will lead to the elevation of blood pressure. And that is why you have certain drugs that will play with those mechanisms, that will affect those mechanisms in order to lower your blood pressure. So you have special cases of hypertension. This one is emergency cases. When I say acute, these are your hypertensive crises, like a sudden elevation of blood pressure. Okay, so you have certain drugs used for pregnancy. I think there's a topic later on pre-eclampsia and eclampsia. So this will be discussed, I think. But here are certain drugs that are used for pregnancy, not because they're the most effective, but because these drugs are actually have a low pregnancy risk factor. Okay, so it is because they are the safest to pregnant women. So DOC means drug of choice. So your methyl dopa. So here are your blood pressure goals based on certain guidelines. You have JNC, which is an older guideline. This one is the one we studied when I was in college. You have your blood pressure reading, which is 140. Like normal is less than 120/80. Then above that is pre-hypertension. Then 140/159. That's your stage 1. Then your stage 2 is 160/100. Greater than or equal to 160/100. When you're talking about this blood, this is your systolic blood pressure and diastolic blood pressure. Always take note when sometimes a number falls within stage 1 or pre-hypertension, you will always follow the higher number. Like for example, I think you're familiar with this. For example, you have a reading like 145/85. 140/85. Let's say that's a reading of your blood pressure. So 140 falls under stage 1, 85 is the diastolic falling under pre-hypertension. You're going to follow the higher number. Okay, so this one is blood pressure goals on ACC or American College of Cardiology or American Heart Association. So they have a different standard. So they have the same 120/80 for normal, but their elevated is 120/129. So having 130, above 130 systolic and above 80 diastolic, 80/89 is now enough for stage 1 hypertension. So ACC usually they focus more on accurate blood pressure, acquiring the accurate blood pressure. Okay, while JNC just shows a certain flow chart. Okay, sometimes JNC has a higher blood pressure requirement, and they have certain flow charts depending on the comorbidities like chronic kidney disease or type 2 diabetes. Okay, so these are the general drugs used for your hypertension. You have diuretics, you have sympathoplegics, meaning they block your adrenergic receptors. And then adrenergic receptors, if you block them, they will lower the effect of your catecholamines, your epinephrine, norepinephrine, thereby lowering blood pressure. Vasodilators, so they widen your blood vessels, thereby improving blood flow. Angiotensin antagonist and renin inhibitor eventually produces your angiotensin and then your aldosterone. Okay, so those types of chemicals, your angiotensin and aldosterone, they are, of course, they contribute to the marked elevation of blood pressure. So these are your drugs. So you have different types of drugs. Some of them are more effective than others, and some are not. Okay, so let's go to your diuretics. So your diuretics usually work. Diuretics usually work when it comes to lowering the blood volume. Okay, lowering blood volume. When you say you lower blood volume, usually blood pressure is elevated by increased blood volume, meaning water plus, like, say, your blood. Okay, so if there's more volume of blood flowing through your blood vessels, there's increased blood pressure. So your diuretics aim to lower that by inducing the elimination of fluids from your body, thereby lowering blood volume, thereby managing your blood pressure. Okay, so that's the general. So you have types of diuretics like thiazides, like hydrochlorothiazide. You have your carbonic anhydrase inhibitor like acetazolamide. Then you have your loop diuretics, which are, for example, your furosemide, bumetanide, furosemide, and then your potassium channel, your potassium sparing diuretics, your spironolactone, which is divided into
Eric,
two
you
categories.
still 8 minutes remain.
Oh, I have 8 minutes remaining, ma'am. Okay.
Yeah, you still
Then-
have 8 minutes.
Okay, thank you, ma'am.
Thank you.
Okay. So with that, given my limited time, so I'll just go through the presentation quickly. Okay. Here, let's go to your other. Oh, I'm sorry. Let's go to your other topics. No, let's go to your other topics. So here, let's go to your drugs for myocardial ischemia, which is the second cardiovascular disease. No, so you have here your angina pectoris, okay, which is basically your the sensation of pain, okay, pressure-like pain caused by your cardiac ischemia. This can either be stable or unstable. When you say stable, this can be relieved by rest. Okay, this can be relieved by rest. For example, these are caused by the following: your atherosclerotic angina, vasospastic angina, and your acute coronary syndrome. Your atherosclerotic angina is caused by atherosclerosis, which is, of course, yung plaque and fatty buildup in your coronary arteries, thereby causing certain obstruction in the blood flow. And this one can be caused by, can manifest as chest pain, which can be relieved by sublingual nitrates or nitroglycerin, or just by rest. So you have vasospastic angina, which this one is more rare, but this one is angina at rest, meaning no stress, no physical activity, it just manifests at rest. That's why it's called angina at rest, and it's actually very painful. This one is rare and sometimes genetic. Acute coronary syndrome is a progression of your stable angina. So acute coronary syndrome consists of unstable angina and your NSTEM, or your non-ST elevated myocardial infarction. Okay, so you have your acute coronary syndrome, and these are your forms of ACS. So your ACS is under your myocardial ischemia, and this one requires a certain measures in order to prevent a progression of, and of course, you're trying to prevent the occurrence and then prevent the progression. So when unstable angina occurs, unstable angina is manifests as much more severe obstruction of your coronary blood vessels. So it presents as that. Therefore, it can present certain things under certain diagnostic tests, like your ECG. It can manifest as It can manifest itself in non-ST elevated, so it can manifest itself a certain way in your ECG. Okay, there are certain your ECG follows a normal sinus rhythm, so it's PQRST, and then when there's certain abnormalities in that reading, either in its form or in its intervals, that's a sign of myocardial infarction, whether in its early stages or its more later stages. So your NSTEMI is characterized by myocardial necrosis or dead tissues in your heart, okay, because of lack of blood flow on the area. So this will manifest as your presence of myocardial markers. So presence of myocardial markers, known like your troponin 1, will lead to the diagnosis of the acute coronary syndrome. So usually they are managed using your antiplatelets, your aspirin. Then certain anti-anginals like nitroglycerin and nitrates will manage the symptoms, the chest pain. And then opioids, if it is a severe myocardial infarction or a heart attack, opioids are needed to manage the pain. Then of course, your oxygen. Oxygen will be used to correct the demand-supply imbalance. In myocardial ischemia, once there's an obstruction, okay, there's always an imbalance between myocardial supply and demand. And that will always manifest itself through limited physical exertion, limited stamina, to just fatigue. And of course,
Pardon, Mr.
internally,
Derek, pardon,
yes,
you have 30 minutes remains.
30.
3 minutes.
3
3
minutes.
minutes.
Thank you.
Yes,
Thank you, ma'am.
3 minutes.
Okay, thank you, ma'am. Okay, so next, cardiac arrhythmia. So let's go to there. So myocardial infarction is also known as your heart attack. So this one is managed by nitrates, your nitrates, opioids, your more opioids. You manage the pain, then you manage the actual obstruction. And then that's when certain invasive procedures will be used in order to restore, or there's this thing called revascularization, or to restore your blood flow. Anti-arrhythmia. Arrhythmia is just your irregular heart rhythm. So this will be corrected using drugs, okay, classified by the von Williams system. Class 1A, 2, 3A, 3, 1A, 2A, 1A, 1B, 1C, class 2, class 3, class 4, and then your miscellaneous drugs. So these are your normal sinus rhythm, PQRST, okay? And they have regular intervals. And then your other types of arrhythmia includes your atrial fibrillation, ventricular tachycardia, and then this one will manifest in your ECG, and of course is a sign of cardiac arrhythmia. And they will be managed using drugs that will eventually restore and reset normal sinus rhythm. Okay. Mechanically, outside of pharmacotherapy, you have the defibrillator, which can reset electrical signals, especially in severe forms like atrial fibrillation. So you have drugs such as lidocaine, amiodarone, verapamil. Magnesium sulfate is also used in supraventricular tachycardia. So for heart failure, this one is caused by structurally damaged heart with poor contractility. So this one, due to untreated cardiovascular diseases, can take a toll in its heart and can lead to structural damage, or your heart being it will remodel. When I say remodel, it will stiffen, and when the heart becomes stiff, its muscles will not be conducive to proper contraction, which will be enough to supply blood all throughout your body. So when that happens, certain drugs will have to correct that dysfunction, because it will lead to systemic consequences. Like for example, it will lead to acute pulmonary edema. So there's backflow of the blood into your lungs. Then you have neck vein distensions, tubular venous pressures, and paroxysmal nocturnal dyspnea is difficulty in breathing, okay, while lying down. Okay, so these are signs of heart failure. So your heart failure is classified accordingly by your ACC. So ACC classifies it based on structure, based on the structural remodeling, and then the presence of symptoms. While NYHA, New York Heart Association, will classify it, which we also follow, will classify it according to your limitations, your physical limitations.
Pardon, Mr. Derek.
Okay.
Yeah, I think that you should finish it because the time is up.
Okay. Okay.
I'm really sorry.
So, okay, ma'am. Okay, ma'am. That's no problem. Okay.
Okay.
So with that, these are the drugs used for heart failure. So heart failure, the concept behind heart failure is if it's unstable, if it's decompensation, you have to compensate, meaning that you have to restore heart functions immediately. So you use inotropics like cardiac glycosides, digoxin, beta-1 agonists like dobutamine, dopamine, um, phosphodiesterase inhibitors, and then calcium sensitizers to increase contractility. Then unloaders, these are drugs that are used for lowering the myocardial demand, okay, lowering the myocardial demand. So therefore, you use vasodilators and diuretics for that. So given that, I can expound more. If anyone has questions, maybe they can ask it. Questions for me, they can ask it later. And thank you, everyone. Thank you all. And I'm sorry for the slight overtime. Thank you, everyone. And that's all.
Yeah, it's okay, Mr. Derek. Thank you. I will explain for the participant. Please, you can ask at the discussion. You can keep your question until the discussion. And we are going to the next speaker, Mrs. C.
Hi.
Hi, do you hear me?
Yes.
My
it's
voice
clear.
is clear in
Yes.
there?
Yes.
Okay. Before we begin, I would like to explain your curriculum vitae first. Mrs. Ming Hin Si is an assistant professor in nursing school, Hung Kwang University. Work experience in 2020, she has a nursing education, bachelor, and also in 2004 until 2020 as a nursing administration and also as a nursing in palliative care. Next, for the specialty is intensive care, palliative care, alternative therapy, nursing leadership, and also e-learning. For the training that she joined is in 2021 as a Ministry of Labor Competition Review Qualification, 2021 also in the TOCA, and in the 2020 in informatic nurse qualifications. For the achievement, in the 2019, it as a hospital reward, and in 2016 as a Best Presentation Award or GAST. Okay, Mrs. C. Okay, are you ready?
Yes.
15 minutes. Thank you. Time is yours.
Okay. Selamat pagi semuanya. Good morning, everyone. It's my honor to talk about palliative care with cardiovascular disease today in this session. So in the very beginning, I want to make sure that it's my voice and the screen are both clearly.
Yes,
Yes?
Mom, it's clear.
Okay. So palliative care is a big issue, but due to the time limitation, so I will just pick some basic and important concept here. So let's go start. when we talk about palliative care, that is relevant across the lifespan from prenatal to geriatric care, regardless of prognosis. So hospice, on the other hand, provides palliative care for terminally ill patients who have less than 6 months to live. So our mission is increasing to access to high quality and evidence-based care that improve patient outcomes such as health-related quality of life. And we see a abbreviation word here, HRQOL. Please remember this word because we will see it later. So another important point is consistent with patients' values, preferences, and goals. So we need to focus on communication, like shared decision-making, to talk about treatment option and advanced care planning. Of course, it should be comprehensive care, but also need to inclusion patient's family and care systems in assessment and management. So according to the clinical practice guideline for quality palliative care is defined as patient and family-centered care that optimize the quality of life by anticipating, preventing, and treating suffering. So it should be integrated into the care of all patients with advanced cardiovascular disease early in the disease trajectory. So in this population, they often suffer the condition in a chronic condition that is usually progressive and may result in or contribute to the ultimate death of the individual. Like stage 4 heart failure is defined as the presence of progressive and or persistent severe signs and symptoms of heart failure despite optimized medical, surgical, and the device therapy. There are about 20 million people worldwide in need to palliative care at the end of life, and there are 94% are adults and 6% of children. So individuals in advanced condition of the heart failure have major functional and lifestyle limitation and may suffer from debilitating symptoms like dyspnea, orthopnea, fatigue, weakness, and anorexia. So these patients usually cannot walk 1 to 2 blocks. Among young children with advanced cardiovascular disease, a common symptom is difficulty feeding. So they often experience poor health-related quality of life as a result of deteriorating health symptom distress and complex care regimen. So we have some because the development of end organ dysfunction, including renal and hepatic insufficiency and pulmonary hypertension, is common, and the end organ dysfunction increases mortality risk and can preclude advanced therapies. So we can see we have 4 predictors here. The first one, of course, they all portend a poor prognosis. And the second one is also predicts mortality in ambulatory patients with heart failure. The third one, of course, we can understand they may affect self-care ability. And the fourth one, social environment factors such as income and disability status, medical insurance, or unmarried status, living alone or at a distance from hospital care, and the history of alcohol or drug abuse are independent predictors of poor outcome, including a survival in advanced heart failure. So we can see lower health-related quality of life related to life-altering physical and cognitive disability. So communication and socialization difficulties are common for survivors, especially in pediatric, Even this treatment such as heart transplantation and the mechanical circulatory support also carry risk and limitation. So their caregivers, as they try to adjust to physical, emotional, and cognitive changes in their loved one, caregivers often experience psychological stress and significant burden. So if we talk about the health-related quality of life in adults, due to their experience symptoms, distress, anxiety, and maybe increase with the worsened symptom to 42% among class 4 patients. So that is not only physical, but also mental. So we can understand that depressed patients with cardiovascular disease have more medical non-adherence, and that will induce continuous and negatively circulation, because non-adherence will combine with worse health status, and then they will need higher healthcare use here. So if we talk about this issue in pediatric, although we talk about the feeding problem a little earlier, it's common.
Pardon, Miss C, you
yes?
have 10 minutes left.
Okay.
Yes.
So the feeding problem will affecting neurodevelopment, and that will induce the caregivers' parent stress, and this stress commonly expand to grandparents, even grandparents. So guidelines from the Heart Failure Society also have multiple recommendation about palliative care. So including the necessary of patients and the family about prognosis, risk of death, including sudden cardiac death and quality of life. So we need to, the important is we need to talk about when the diagnosis is made sure, and of course throughout the illness course, and with the patient's permission, key family members and any appointed healthcare agent also should be included in this discussion. And if we can integrate palliative care in the management of patients with advanced cardiovascular disease, may providing the following benefit. So we can make better consensus and also improve the understanding of disease and prognosis. That is not only for patient and family, but also for our medical care team. And we can have better understanding of treatment of symptoms and the relief of suffering. So we can have better preparation for end of life and also the bereavement supportment. But also we have some barriers here, like reluctance of providers to refer patient to palliative care. Maybe the provider is discomfort in communicating with, talk about this issue, like some physician or medical care staff, they will think that is a fail to take care for themselves. So they won't be talk about or try to transfer the patient to palliative care aggressively. And another one issue is limitation in payment symptom. So I think that will be my final slide. That is the important one is communicating in palliative care. So when we providing information, that is very important. We should to know if we want to provide prognostic information to a patient and his or family, it's not a straightforward process, and the information needs to be easily understandable. And remember, all patients and the family want to be told about prognosis is lacking. So that is my some talk about palliative care with cardiovascular disease. And I believe we can talk more later in discussion, right?
Yes, Mrs. C.
Yes.
We will continue for answer the questions in the discussion. Thank
Okay.
you. Yeah, I hope Mrs. C and also Mr. Derek still on Zoom. Yeah, because we are going to have a discussion after this.
Okay, I will giving you. Thank you.
Yeah, thank you. So for the last speaker, Mrs. Marilo, have you hear me?
Yes, ma'am.
Okay. Do you hear me clearly, my
Yes.
voice?
Yes, ma'am. How
Okay.
about me, ma'am?
Okay, I hear you very clearly. Okay, I would like to explain your curriculum vitae first. Mrs. Marilo Marasigan Pamintuan as a registered midwife and registered nurse. For the education, Doctor of Education major in Educational Management in National University Manila, and also Master of Art in Nursing, major in Nursing Service Administration in Emilio Aguinaldo College. Next, for working experience as a program head in School of Midwife and Caregiving in Emilio Aguinaldo College, and also as a Dean School of Midwife and Caregiving in Emilio Aguinaldo College. For the research speaker, she as a Meresing Institute School and Technology Kalipayan Hotel Das Marinas, Cavite at April 4, 2018. Next, she also as a facilitator in a basic home management and healthcare services, and also as a director center for training and continuing education at June until now. Next, for the international award nomination, she got nominal of Princess Srina Garinda Award Foundation and also in Ministry of Public Health in Thailand. For the research involvement, she is as a co-author for the title Engagement of Teenage Mother Partner in Childhood Development. Next, for the poster making, she got Partner of Teenage Mothers, Paternal Engagement Partner in Child Development, Basis for Health Education Plan. And for the other assignment, she has an internal auditor at January 2017 to present as a representative of the school in performing internal audit on quality concern as stated in the quality management system. Okay, Mrs. Marilo.
So good morning. Thank you.
Yeah,
Thank
good
you, ma'am, for
morning.
the very long
Magandang umaga. Yeah.
magandang umaga sa inyo.
Okay, you have 15 minutes to explain your presentation. Time is yours.
Actually, the presentations I think is within the organizer with so I request to flash.
Okay, we will help you.
Yeah.
Wait a minute. Yeah. Have you seen it?
Not yet.
Have you seen it?
Not yet.
Not yet. Not-
Okay.
Okay.
So thank you, everyone. So good morning to all, especially to our organizer for being kind and patient, providing updates on the seminar. So in behalf of Emilio Aguinaldo College School of Midwifery, Manila, it is our honor to be with you today as your guest speaker for this seminar. My task with you is to discuss about the management of pregnancy with preeclampsia. So next slide, please. Yes, ma'am. Next slide, please.
Okay, wait a minute. I'm really sorry for the. Okay, have you seen it?
Yes. Okay, next slide, please.
I'm really sorry for the trouble.
Okay, so in normal pregnancy, the cardiovascular dynamics alter to meet the increased demand of fetoplacental unit. This increased the workload of the heart quite significantly to augment the needs of the mother and the baby. Thus, the major cardiac changes occur. Next slide, please. An increase of cardiac output of 30 to 50% to meet the demands of the mother and the growing fetus. The plasma volume increases and the RBC, similar to increased blood volume but decrease the hematocrit level, thus resulting to physiologic anemia. Next slide, please. So the cardiac output, okay, is contributed by our heart rate and the stroke volume. However, during the pregnancy, it increased the heart rate of 10 to 15%, and the stroke volume is also increase of 20 to 25%. Now, the stroke volume is influenced by our preload, afterload, and the contractility of the heart. Our preload is the amount of blood entries in the ventricle during diastole, while our afterload is when your ventricle contract, injecting blood to aorta and atrial resistance. If the blood vessel wall damaged their ability to dilate or to constrict, the adapt of the hemodynamic change occur or impaired. Also, the contractility of the heart. It refers to the force of the contraction of the heart muscle. Please, next slide, please. Now, it's occur, so in case that the afterload increases, so the increases the pressure, so increase also the blood pressure. It is due to our atherosclerosis or plaque in our blood vessels and the vasoconstrictions and contractility. So the pregnancy-related disease, which is our preeclampsia, is evidenced by increased blood pressure and protein in the urine. So preeclampsia is a pregnancy-specific disorder involving widespread endothelial functions and vasospasm that occur after 20 weeks of gestation. Next slide. Now, what are the predisposing factors? Although the cause is unknown, but we have a predisposing factor that this disease is caused by primipara, higher incidence of below 17 years old and above 35. Low socioeconomic status or low protein intake. History of chronic hypertension of the mother or history of H-mole, diabetes mellitus, multiple pregnancy, polyhydramnios, renal disease, and heart disease. Also by true genes. Okay, so next slide, please. So the preeclampsia, we have triad symptoms. So the triad symptoms is we have swelling or edema, protein in the urine, and atrial or arterial hypertension rather. Okay, so what happened? Next slide, please. What happened if the client there is an increased BP, okay, or there is a vasospasm? So there is a vascular effect on the vascular effect. Number one is you have a vasoconstriction. So if there is a vasoconstriction, there is a poor organ perfusion and it effect on the increased blood pressure. So we have also kidney effect. So decrease glomerular filtration rate. So thereby increase the blood volume or decrease also the urine output and increase the out of the urine of the protein or decrease urine output and increase the protein excrete. Okay. In interstitial effect, so there is a diffusion of fluid from bloodstream into interstitial tissue. It causes edema because of the fluid shifting. If our blood vessel decrease the amount of protein, since that the protein is magnet the water, so the tendency now is the fluid is shift to external, okay, and that cause of edema. Next slide, please. We have the signs and symptoms of preeclampsia. So our signs and symptoms, the blood pressure is 140/90. And then if it's severe preeclampsia, we'll have 160/110. Protein is +1 to +2. If severe is +3 to +4. So edema is digital edema, so it's +3 and +1, +2, or dependent edema. If it is severe preeclampsia, we have pitting edema +3 and +4, and generalized edema. So we can see usually in the ring or the wedding ring, they cannot remove. Okay, so and also they have a generalized or anasarca. The face also have an edema. Okay, weight gain, so 2 pounds per week. That's supposed to be 1 pound per week. So more rapid weight gain in the severe preeclampsia. So the urine output is not less than 500 ml rather, but in severe there is a less than 500. Headache is occasional in mild preeclampsia, but in severe preeclampsia there is a severe headache. So visual disturbance and epigastric pain. So in mild preeclampsia, absent. Okay. While the severe preeclampsia, there is a photophobia, blurring of spots before the eyes, and right upper quadrant pain. So sometimes it's an aura for eclampsia. Okay, next slide, please. Now, as a midwife, okay, so our role is during antenatal visit after 20 weeks of gestations and beyond. So we get the maternal data. So we have demographic data, we have a maternal history, and identify the high risk of pregnancy. So next is we perform the physical examination and the vital signs. So if also we interview the client if there is a pre-existing conditions like hypertension, autoimmune disease, diabetes mellitus, chronic renal disease, multiple pregnancy, and polyhydramnios. If yes, okay, if yes, so refer to OB/GYN to continue management, because as a midwife here, so our responsibility is to manage client with low risk, okay? But if no pre-existing conditions, the client, so identify if no risk, so you continue routine antenatal care. But if there is a risk, so close monitoring of blood pressure, protein during antenatal visit. So every 2 weeks, and check for fetal movement. Okay, so have to check again the blood pressure. We always monitor the blood pressure. If
Pardon,
with
Mrs. Merlo,
hypertension,
pardon,
yes,
you still have 17 minutes.
okay. If there is an hypertension, if yes, begin activities to confirm the diagnosis of hypertensive disorder of pregnancy and classify the client. So we check for the request the doctor or refer to the doctor for consultation of for monitoring and laboratory. If there is no hypertension, so continue routine antenatal care. You have also, if there is an hypertension, you check the presence of alarm signs or the danger signs of pregnancy, which is yung CABs, the chills, abdominal pain, bleeding, and I forgot this. Okay, so next is if there is a presence of alarm signs, so refer the client to OB/GYN to evaluate the severity of the disease. Okay, so next slide, please. Next slide. Yes, next slide. Next slide. Okay, so what no. Backward, please. Backward, please. For the management of the client, okay? So we have ambulatory management or home management is allowed only if the blood pressure is 140/90 and below. There is no protein in the urine and there is no fetal growth retardation. So and the patient is not young primipara. So we advise also bed rest. Okay, the woman should be in a bed rest for a part of a day and free from physical and emotional stress, because we all know that if the client is unstressed, there is a precipitating factor to induce hypertension or to increase hypertension. So also we have to, the woman should consult the clinic as often as necessary. Diet should be high in protein to correct the edema, and carbohydrates with moderate sodium restrictions. Okay, so to correct the fluid and electrolyte imbalance. Also, request the patient to elevate the foot part, especially if they have positive edema. So elevate the foot part or rest in between, okay, at least every 2 hours. Okay, then next slide po. Hospitalization is necessary if condition is worsened. Provide detailed instruction about the warning signs. So as I mentioned, so we have epigastric pain, visual disturbance, severe continuous headache, nausea, and vomiting. So next is for hospital management. If the blood pressure goes up 140 over 90 and above, okay, so bed rest is one of the most important principles of care. Rest the client in a left lateral position to promote blood supply to the placenta and the fetus. And to avoid distractions of our client, leave the BP cuff on the patient's arm so as not disturb the patient when placing every time we check the blood pressure. Okay, so I think that's all my presentation. Thank you. I think I meet the day at the time.
Okay, thank you.
So
Please stay in Zoom, because after this, after the last speaker, Mr. Azran, we will have a discussion.
okay, thank you.
Yeah. Good morning, Mr. Azran.
Good morning.
Yeah. Have you hear me clearly?
Yes, very clear. Crystal.
Okay. I will explain your curriculum vitae first.
All right.
Mr. Azran bin Ahmed is from Malaysia. He is as a Deputy Manager Physiotherapy and Rehabilitation Department at Institut Jantung Negara Kuala Lumpur, and also highly experienced senior exercise physiologist specialist with cardiovascular and thoracic care with excellent communication skills. And also, he trained in the United Kingdom with NHS Teaching Hospital as an exercise physiologist for cardiac rehabilitation phase 1, 2, 3, and 4. Next. For education or qualifications, he pursuing PhD in doctoral philosophy in health sciences in University Technology Mara, and also Master of Science in Cardiac Rehabilitation in University of Chester, United Kingdom. For the career history, from the 2000 and until 2005, as a physiologist community cardiac rehab at St. James Teaching Hospital, NHS, UK. Next, for the training, he got British Association Cardiac and Pulmonary Rehabilitation, ICHPR 2017 certificates course. And also good clinical practice workshop organized by IGN and Cyberjaya University College of Medical Science. And also has a certificate of Professional Development Mentoring and Assessing in Practice by Liverpool John Moores University, United Kingdom. Next, for the adjustment in Langkawi, Malaysia Ironman finisher 2022, and also has Kuala Lumpur Standard Chartered Marathon finisher 2022, and got first place and Diamond Award thesis in 5-minute series 2022 for Asia Pacific universities. There's a lot of achievement that Mr. Azran got. For the other services, as a team leader cardiac rehabilitation, and also monitoring cardiac rehab recruitment and enrollment, and to ensure the cardiac rehab program is profitable for organization. For the experiences case, had experience to treat to patient lung transplant, for patient heart transplant, and also sick patient with ventricular assistant device, such as model HeartMate 2, hardware, and Turek. Okay, Mr. Azran, have you
Alright.
ready?
Yep, Madam Moderator, let me share my screen.
Okay, wait a minute. We will help you to share screen. Have you seen it?
I use my own slide, which is controlling.
Okay, please slideshow.
If everyone seen that,
Okay.
okay.
Yes, we are seeing it.
All right, thank you very much, Madam Moderator. Hello and good morning from Kuala Lumpur, Malaysia. So I don't have to elaborate about myself because Madam Moderator already explained and briefed this morning about myself. So my topic today is management of physiotherapy for elderly with cardiovascular disease. All right, who is defined as elderly? Typically, the elderly has been defined as the chronological age of 65 or older. People from 65 to 74 years old usually considered elderly, while those over 75 years old are referred to as late elderly. What are the most common with elderly? They have a urinary incontinence, that's very common. Sleep problems can affect their quality of life and can contribute to falls, injuries, and other health problems. Delirium, dementia, fall, osteoporosis, weight loss, and last but not least is the cardiovascular disease. All right, cardiovascular disease represent a major burden for individual patient and society in terms of healthcare costs and organization. Because CVD is strongly related to age, and in view of the worldwide aging population, the number of older patients with CVD is increasing rapidly. This trend raises a particular challenge for cardiac rehabilitation for older patients hospitalized for cardiovascular disease. So in older patients, cardiovascular disease is often accompanied by other heat-related problems that could interfere with rehabilitation, complex multimorbidity, polypharmacy, cognitive problem, and impair functional, nutritional, and psychological status. Okay, this is the evidence in this population, which is they need the cardiac rehabilitation. Research has shown that the cardiac rehabilitation can offer substantial benefit for all the patients with heart failure after CABG surgery or heart valve replacement and after an acute cardiac event, which is the unstable angina pectoris and acute myocardial infarction. And moreover, all the patients with CVD are perhaps more likely to benefit from the multidisciplinary approach that characterized by cardiac rehabilitation. However, despite proven benefit, many older patients with CVD do not receive cardiac rehab in daily practice. Several reasons for this, which is underuse, can be identified. So, physiotherapy management and cardiac rehab guidelines actively performed in many Western countries. Effectiveness and safety is established, which is clinical practice guideline in physio management of cardiac rehab has been developed. Consideration and circumstances, medical and scientific evidence, documenting systematically organized reference for medical professionals. So class of recommendation and level of evidence, which is class 1 indication, is very strong recommendation, which is American Heart Association class 1 guideline recommendation for referral for cardiac rehab include the following condition, which is myocardial infarction, PCI, CABG, chronic stable angina, heart failure, and PAD. So the initial years, which is a physio involvement in elderly with cardiovascular disease, done in the ward post-surgery, breathing exercises, physio involved with active exercises, ambulation, home exercise program. So cardiac rehabilitation mainly have three phases at the moment. So most of the country, they practice the phase 1, phase 2, and phase 3, which is hospitalization for phase 1, phase 2, ambulatory outpatient, and phase 3, which is maintenance. So the activities involved, which is early mobilization, personalized individual program, patient and family education, which is to increase the patient awareness to exercise, reassure the patient about future progress and follow-up. So the benefit, which is the shorter hospital stay and improve active daily living and functional for the patient, especially the elderly. Inpatient phase 1, as soon as possible after admission for surgery, we will do the pre-op physiotherapy education, patient and family members. So basic information and reassurance expectation after surgery, which is we'll do the mobilization, family involvement toward the surgery, and outpatient elderly cardiac rehabilitation. Basic information and reassurance that we give it to the patient, reassurance and brief explanation of a cardiac condition, treatment and procedure, surgical incision, pain support, drugs and non-drugs, effect of anesthesia of the respiratory system, sleeping position after the surgery, and getting in and out of bed. So inpatient phase 1, basically what we do is a mobilization program, active exercise in bed, in ICU and wards, to prevent deep vein thrombosis and pulmonary embolus. So that's a benefit of early mobilization for elderly, which is we want to minimizing complication of bed rest, promoting improved function for patients, shortening the duration of mechanical ventilation, reducing length of hospital stay and reducing overall hospital costs and improving patient quality of life. So the indication, basically what we do, which is that's an indication post myocardial infarction, chronic stable angina, heart failure after coronary artery bypass graft surgery, after percutaneous coronary angioplasty or intervention, heart valve repair or replacement, heart or heart and lung transplantation, correction of congenital abnormalities, peripheral artery disease, mechanical circulatory support, etc. So the initiation, physio always face an obstacle with elderly patient due to weaknesses and pain. Immediately upon respiratory and hemodynamic stabilization, generally within 24 to 48 hours after admission, we will screen for contraindication. So this is some of the contraindication: hemodynamically unstable, medical or surgical status necessitating immobility, active myocardial infarction, unsecure airways, chest not closed or chest reopened, active GI, TB, and intracranial pressure more than 20. So the safety, this is a safety measure. We look at the heart rate, blood pressure, SpO2, and PO2 as well. So safety measure, we look at the respiratory rate, pain score, and blood investigation like HB, platelet, INR, potassium level. So the frequency that the physio will see the patient, basically 2 to 4 times a day is recommended, depend on the physiotherapy assessment and patient needs. So that's a special consideration. We have to look at the patient, especially the elderly. Hypertension, we monitor hypertensive or hypotensive exercise response, measure BP during exercise. Diabetic, which is we monitor blood glucose level. For heart failure patients, slightly lower performance, we know that they not be able to push to the limit. So the lifestyle habit, which is physical activity behavior, begin at higher exercise workload if patient is active. So exercises, basically what physio done in the ICU or wards, passive active assisted, active and resistant exercises, bed mobility training, turning side to side, bridging, supine to sitting, bedside sitting, balance training, sitting, static, dynamic, standing, static or dynamic, gait retraining, and endurance training. So the common goal, basically, we want to achieve the bronchial hygiene to achieve the highest incentive spirometer value, to achieve full FSS, which is the ICU score. Score range about more than 7. So the activity what we do is rolling, supine to sit transfer, sit to stand transfer, sitting edge of bed, and walking 45 meters. 30 seconds sit to stand, minimum of 14 times. So and then 6-minute walk test to achieve the highest distance possible. So the determination of criteria for elderly for cardiac rehabilitation in the ward or ICU or in the general ward, we look at the heart rate, we look at the blood pressure, respiratory rate, and SpO2, and also we look at the patient sign and symptoms. Exercise progression. Progression of exercise should be individualized and based on patient risk stratification. underlying disease states, exercise tolerance, goals, durations, which is initially to achieve 10 continuous minutes of exercise, increase 1 to 5 minutes per session, goal of 40 to 60 minutes duration should be achieved before intensity is progressed. And then the intensity, we use the RPE, which is box scale. And we look at the box scale, which is 11 to 14, somewhat hard to hard, to consistently exercising at 12 to 16, moderate to hard. And then we use the outcome measure for elderly as well. We look at the insanity parameter. We use the FSS ICU, 30-second sit to stand, 6-minute walk time. 6-minute walk time. This is the common one, right? And there are multiple outcome measures to be used in clinical practice. This is what adopted by our organization, Institute Jantung Negara. So cardiac rehabilitation, phase 2. Just now I mentioned about phase 1, inpatient. Now it's outpatient, phase 2. So it's more about ambulatory elderly outpatient. This activity begins soon after discharge from hospital. We will conduct the secret training, individualized program, low to moderate intensity, group education for elderly patient and family members. The benefit, which is the supervised, monitored program, and patient return to work safely and sooner. But most of our elderly patients, they are retired, so they're not going back to work. So they just, just continue active daily living. And then another benefit, which is the reduced stress. So the exercise training program, which is cardiac rehab phase 2 exercise prescription, we put the intensity at 50% to 95% heart rate reserve, which is the rate perceived ejection at 11 to 14. And intensity resistance training, about 30% to 60% one repetition maximum, and about 8 to 12 repetition, 2 to 12 sets. So the modality is cycle ergometer, treadmill walking, secret training, and the duration will take about 20 to 80 minutes per session, including warm-up and cool-down exercise. So basically what we're conducting in KL in Malaysia is a group-based and individualized supervised. So exercise progression of exercise should be individualized and based on patient risk stratification. Previous recent exercise record that patient reported, for example, like duration, distance, repetition, sets, and weights.
Pardon, Mr. Haska. Pardon, Mr. Azran. You have 15 minutes.
All right. So the duration basically initially to achieve about 10 continuous minutes of exercise, and intensity the same. We use the RPE box scale. So that's a special cardiac rehab consideration for elderly with cardiovascular disease, hypertension. Most of the elderly, they have hypertension, diabetes mellitus, PVD, respiratory problems, obesity, skeletal disorder, and musculoskeletal problem. That's very common, yeah. And then special consideration for elderly with CVD, which is common thing is hypertension. Approximately about 90% of elderly identified as hypertensive. And secondary hypertension is usually a result of renal, endocrine, or vascular abnormalities. Raises BP over a period of years causes damage to the arteries and fat strain of the heart and other organs. So the exercise consideration, we look at the mode, frequency, duration, and intensity is the same as cardiovascular disease patient. Training at lower end of the recommended range, which is 40 to 70% VO2 max or 60 to 80 heart rate maximum, to be at least as effective in lowering BP and is safer than high intensity exercise prescription. And the effect of medication of BP become exaggerated during exercises. So especially when the exercise is of sufficient intensity for the skin vessel to become significant dilated. So the second one is just hypotension. Small proportion of elderly has low BP, and this is normal for them. And symptoms include faintness, dizziness, cold hand and feet as a result of reduced blood flow to the brain, and palpitation, sweating as a result of body releasing adrenaline in the attempt to restore blood pressure to normal level. So the treatment, which is we lie patient down, check the BP not improving, should leg be raised, and then loosen the clothing, await recovery, which may take about 20 to 30 minutes. Exercise consideration, thorough, graduated warm-up and equally cool down will be lessen the incidence of post-exercise hypotension. Immediate change from lying, seated to standing position should be avoided, especially during the condition phase of the class when the participants are hot, blood vessels are dilated. If a patient uses the DTN spray or put under the tongue, either as a preventive measure or at onset of angina, therapy should ensure the patient remains seated after administration medication. So diabetes mellitus, there's a 2, hyperglycemia, and hypoglycemia, most patients have been taught how to manage and will know how to test of the presence of ketones. So give a sweetened drink, glucose tablet immediately, and patient should not resume exercise for that session. Exercise consideration, advise patient to monitor their blood sugar level before exercising. If level are higher than 10 millimole, be monitored again 10 minutes after the start of exercise. If the levels are falling, exercise can continue. If they are rising, stop exercise. For example, like exercise which spikes blood sugar level is very dangerous. So monitor blood sugar before and after exercise. The insulin dose may need to be reduced on exercise, or exercise days should be avoided when the insulin is at peak effect and should not injected into lymph, which is to be exercised within the next 12 hours, which is it will increase the rate of insulin drop. So neuropathy, damage to the peripheral nerve as a result of diabetes may lead to loss of sensation and causes of numbness of the feet. Autonomic neuropathy may also present, in which case patient will exhibit abnormal heart rate and BP response to exercise. So consequently, heart rate may not be a reliable indicator of intensity. Immediate changes posture should be avoided, for example, like sitting to standing or lying down to stand. So exercise consideration, patient with advanced retinopathy should avoid activity which involve excessive pain or discomfort and spikes BP. So do not bend over. The head must be remain above the level of the heart or at least not below it. So next one is the PVD. Severe PVD causes cold, painful feet, can lead to gangrene of the toes. Patients suffering from severe PVD must be exercised carefully. Skin of the feet is easily damaged and heals slowly. So exercise consideration, daily exercise, walking intermittent with rest period should be prescribed. This encourages an increased blood flow to greater oxidative capacity of the muscles, which will increase exercise tolerance and alleviate symptoms. Progress duration intensity exercise gradually. So next one, which is respiratory problem, bronchitis, asthma, emphysema. Exercise consideration, exercise may induce bronchoconstriction, particularly in cold condition, and bronchospasm induced by exercise is not uncommon. Bronchodilator can be taken as a preventive measure prior to exercise, but bear in mind it will increase the heart rate. Warm-up is recommended, will also lessen the chances of provoking chest tightness and wheezing. Elderly patients are unlikely to exhibit improvement in pulmonary function as a result of exercise, but will increase their exercise tolerance as a result of peripheral adaptation to increased level of activity. So obesity, defined as a BMI more than 30, habitually inactive. Exercise consideration, intensity should be at the lower end of the normally prescribed range, which is 60 to 80 heart rate max. Traditionally, 2 to 3 times a week, which is we target about 300 calories per session, 20 to 30 minutes of the remaining days of the week. Brisk walking activity, no high impact activity, emphasize good posture to the patient. Supine position should be avoided. This is because they embarrass by getting down into and up from the floor. Lying flat also can restrict breathing. So we use the RPE to monitor intensity. Fat around neck and wrist make pulse palpation is difficult. Yeah? So skeletal disorder, arthritis, osteoarthritis, rheumatoid arthritis, replacement surgery, and osteoporosis. Exercise consideration, we maintain a good range of motion is a priority. Mobility and flexibility should be prescribed on a daily basis. Strengthening exercise, we maintain joint stability, and diminished pain are extremely important, but should not be performed without load on the affected joints. Weight-bearing activity need to be excluded. Non-weight-bearing activity, for example, like swimming and cycling, may be comfortable for elderly patients. No high-impact movement. Good posture must also be emphasized as elderly patients tend to adopt lax positions. So musculoskeletal problem, frozen shoulder, tennis elbow, sciatica. Exercise consideration, action should be avoided. Passive movement may be performed within pain limits. One pain subsides. Initiate mobility exercise, which should be intensified until full recovery is achieved. Analgesic and gentle mobility exercise should be recommended. And for long elevation, exercise to strengthen the muscles are recommended. And hearing and eyesight both tend to deteriorate with age, although variation between individuals is sensory loss inconsiderable. For some, impaired hearing and vision may be source of anxiety and lack of confidence. So exercise consideration, instruction must be clear, precise, and unhurried. Visual demonstration combined with verbal explanation is the most effective means of communicating with individuals and groups. If written handout are supplied, exercise card used, ensure that they are easy to read and that any diagrams are clear. So in conclusion, not only one more elderly people surviving from cardiac event, but because patients are less likely nowadays to be referred to cardiac rehab on the basis, the number who benefit from cardiac rehab is increasing. It's hoped that physiotherapy and multidisciplinary team will make a significant contribution to helping all the patients maintain favorable lifestyle change adopted during cardiac rehabilitation. Thank you. All right, I pass it back to my moderator. Thank you very much. Any question?
Okay, thank you, Mr. Azran. Okay, because of all the speaker already explained the presentation, we will go into the discussion. Okay, maybe the participant will raise your hand, or maybe the committee will help me to show the question from the comment section. Okay. Okay, there is some question. First, for Mr. Derek, from the Miss Iwung from the Stikes Selogorjo, I want to ask about drug administered. If we don't have drug opioid to relieve pain in AGS patient, are there any optional drug beside opioid? Thank you. Mr. Derek? Mr. Derek?
Hello. Oh,
Yeah.
oh, hi. Can you see
Yeah,
me?
okay.
Hello?
Do you understand the question from Miss
Oh,
Iwung?
yes, sir. Yes, ma'am. So regarding
Okay.
the question, so regarding if there's no, am I getting this correctly? If there's no opioid available for relieving pain in, let's say, acute coronary syndrome, are there any optional drugs besides opioids? So when you say acute coronary syndrome, there's a certain spectrum, right? So unstable angina and STEMI, and then yung STEMI. So when it comes to heart attack, of course, there is a certain chest pain that accompanies it, and therefore opioids are used. So if it is not available, usually this one is not ideal because there's a lot of available opioids in the market. Like for example, that will be administered intravenously in this particular case. So in a case of myocardial infarction, so ideally you have to administer morphine, intravenous opioids like morphine or even meperidine, petidine. I don't know how it's called here there. But when in the absence of opioids, there are certain, based on studies that I've read before, there was the testing of what do you call this, intravenous acetaminophen or paracetamol. But this one, the efficacy of this one is not that high. Okay, the efficacy of that. Why is it why they went to paracetamol other than NSAIDs and they skipped NSAIDs or your, let's say, mefenamic or ibuprofen? Because ibuprofen, your NSAIDs, generally they will worsen patient outcomes. They will even worsen your blood pressure. So there is a certain contraindication regarding that. So they went straight to paracetamol. But in acute, like critical myocardial infarction, there is this option as well of sedation because there's an assumption that there is cardiac, like catheterization or angiography, then catheterization, angioplasty that will accompany it. So another from my readings, another alternative to that is just straight to go to sedation along with oxygen, maintaining oxygen supply, administration of intravenous nitrates, and the administration of aspirin. So they went straight to sedation using, there's this drugs called propofol or dexmedetomidine. Okay, so those type of sedatives in order to go straight to that and then perform yung PCI or percutaneous interventions. So they went straight to that. So usually morphine, the role of morphine in there is not really for improving patient outcomes, but only for real symptomatic analgesia or pain relief for the severe pain that myocardial infarction or heart attack induces on the patient. So that's why if there is another alternative, they went to acetaminophen, but there's unproven efficacy. But or there's another reading that says that you can go straight to sedation or anesthetics. But this one, of course, will always be in discretion of the. I'm answering this one based on my clinical experience, based on my clinical education. But this one will always be upon the discretion of the physician involved. Regarding the, I think I've read part of the second question. Oh no, the first question, is that enough? That question.
Oke. Mungkin Bu Iwung mau ada yang mau ditanyakan lagi atau sudah jelas?
Yeah, so is that
Okay.
anymore?
When we wait Bu Iwung untuk merespon ya. When we wait Bu Iwung to respond, we going to the second question for Mr. Derek.
Okay.
Thank you,
Hypertension
clearly.
is not. Yes, Bu Iwung?
Thank you for the explanation.
Okay. Okay, we going to the second question, Mr. Derek. Hypertension is not cured but controlled by using drugs such as bisoprolol, fumarate, captopril, and others. If people with hypertension are in good condition, they will continue to take drug to control blood pressure to remain stable. If that's the case, what about the complication that occur due to taking drug for life? From Emalia.
Okay, thank you, Emalia, for that question. So to answer this one, I have let's think of this. I have several things to consider when it comes to stopping your antihypertensive medications. So regarding this one, so in this case, you are talking about is hypertension in the matter of if you have hypertension and you have to control, not cure hypertension, but control it with drugs. What will happen? What are the complications? You know, what are the certain complications that could happen when taking it for life, right? So this one, so what's the? Let's think of it in this regard. So hypertension in and of itself is the elevation of blood pressure. But there are certain factors that may contribute to it. Okay, there are certain factors that may contribute to it, and those factors can be detected. No? They can be detected. Those factors can easily be detected and can be attributed to lifestyle modifications or certain comorbidities. And then those risk factors is either modifiable by lifestyle modifications or not modifiable by lifestyle modifications. When you say modifiable by lifestyle modifications, this one is anything regarding your diet. So reduction of sodium, exercising, so preventing, solving your sedentary lifestyle or low activity level, being overweight or obese. How about smoking as well, alcohol intake, and stress? So those type of modification, those are risk factors that can be modified or can be changed personally by the patient. Those are non-pharmacologic suggestions that no need for medicine in order that the patient can change for themselves to improve their condition. Then there's the other things that are comorbidities that are not modifiable by lifestyle modifications. Like, for example, you might have high cholesterol as well. You have diabetes. You have some sort of hyperthyroidism, for example. That's a secondary hypertension. You have family history. It is in your genetics. You're of a certain age, like older age, let's say close to geriatric, close or at geriatric age. Or you might have some sort of sleep apnea. So anything regarding that, those are unmodifiable risk factors. When you are prescribed antihypertensive meds for your high blood pressure, whatever, let's say at your age, if there's a suggestion that you can solve it by lifestyle modification, by exercising, eating healthy, then you made significant positive progress and strides towards that. Then by constant blood pressure, by continuous blood pressure monitoring, you're showing normal readings. In my readings, there is a possibility in which antihypertensive medications can be stopped within, let's say, 6 months or 6 to 2 years of normal controlled hypertension using drug. There's a consideration in which it can be stopped in and of itself. But the problem is the comorbidities. The comorbidities that can occur with antihypertensive medication, that can occur with hypertension. So in those cases, you have to treat those comorbidities. So your cholesterol, diabetes, other type of medical conditions that can cause secondary hypertension in order to treat your hypertension. And in that regard, antihypertensive medications cannot just be abruptly withdrawn. Okay, and there's always a continuous check-up with your physician in order to make appropriate clinical decisions on that regard. So to answer your questions, it's not necessary to take antihypertensive medication if you're for life, if you're making significant changes with the modifiable risk factors that you have. Your weight that can be changed by lifestyle modifications or living a healthier lifestyle. So if you're making significant progress on that part, then there's no antihypertensive medications can be withdrawn eventually. But the problem is the comorbidities and the accompanying polypharmacy and problems that can arise from that. So usually it's not really, it's a complicated situation that requires a multidisciplinary approach. Okay, and of course, that is why we have to constantly update ourselves when it comes to interventions.
Okay, untuk
Is
Miss
that all?
Emilia, it's clear, or maybe there is more
Thank you
question?
about the explanation about the we need a lifestyle. Thank you, Mr. Derek. Have a nice day.
Have a nice day, Emilia.
Okay, I think that Miss Emilia really understand about your explanation, Mr. Derek. Okay, we're going to the next question. Okay, for Dr. C. Dr. C, do you hear me?
Hey, yes.
Okay.
Hey.
There is one question from the nursing program, Stika Gorjo. We know that people who living with cardiovascular disease must undergo the treatment for the rest of their life. How do we communicate to the patient and families if the patient is still in the stage of denial of his illness?
Okay, it's really interesting. Okay. It's a really an interesting topic. Sometimes really patient and the family, a special family, the condition in Taiwan is very often to met because the family may be afraid the patient cannot tolerate the effect of the disease. But in actually, we need to say the condition is sensible, especially patient will sensible their physical condition. So sometimes we will have family over that don't talk too much to patient, but that is need part and part, step and step to talk to patient and family. I think that is no meaning if we don't have that patient know the disease condition. So we will discussion with them, maybe not speak out too much in one time. Maybe that we can part and step to talk with them. And there must be that the family knows the time may be limitation. So if patient have no idea of their situation, they may not can to plan what they will want to do in the last time. I think that will be made a big story after patient go on. So in medical care teams rules, we still need to try to discussion with them about this issue, but maybe we can adjust the issue time and time. Yeah. So is that clear?
Okay. Maybe any other participant who want to talk or ask about palliative care? So the important thing that we should communicate with the patient and families. Yes, Dr. C. If we talk about palliative care. It is also according to the culture that will be some factor will impact to the denial stage about the culture.
For me?
Okay, maybe when we talk about palliative care, in Indonesia, we have a lot of culture. So it's maybe the perception of the culture is also maybe a factor, risk factor to communicate with the family and also patient.
Yes, I believe so. And also in my last slide, we talk about how to discussion some difficult issue with patient and the family. And that is one important skill is not straightforward and make it easy to understandable. I think that will be important. And sometimes maybe we can try that patient and family speak first to understand what they really want and their values is for what. In Taiwan, we have a much struggle between patient family and the medical care team. It's about aggressive treatment or and we sometimes we will make the treatment option changes, but as it's asking by patient or family, because palliative care team maybe can relieve the symptom, physical symptom. So when patient and the family they feel, oh, seems like I'm better now, and they will change their treatment option to aggressive. That is sometimes we usually to manage this condition, but that's really needed to be careful, because the physical condition change to better is maybe cannot make sure that patient can also tolerance a new treatment. So that is a risk we need to let them know before they really to change their treatment option.
Okay, thank you. Thank you, Dr. C. We're going to the next question. Okay, we have a question for Dr. Marilo. Do you hear me, Dr. Marilo? Dr. Marilo?
Sorry.
Okay.
Yeah, all right.
There's a question. What can the family do to the family member if the family member experience the emergency condition of preeclampsia in home?
So, first, the family members or the patients is also give health teaching.
So for watch out the danger signs of pregnancy. And if they experience that, they go to the hospital management, because that first they contact, so they contact their OB/GYN or the midwife for giving a advice, and then immediately refer to the hospital for further management.
Okay, we should contact the midwife first around the home, right? To
Yeah.
advise to the hospital if there is a pregnant woman got the preeclampsia at home.
Yes.
And also, if some pregnant women do not detect preeclampsia during pregnancy, but at the end of pregnancy, signs of preeclampsia appear at the end of pregnancy, what should be done to prevent eclampsia from occurring in the referral process far from health facilities? Because sometimes the patient family referral process difficult to give information about it. From Miss Nella.
Actually, so what we did as a midwife in the healthcare facilities, we give a screening during the prenatal visit. So if the patient determine that they have a signs of pregnancy or signs of preeclampsia, they are referred to the OB/GYN for the further management, because here in the Philippines, the midwife only taking care of is the low risk pregnancy. So if they refer to the doctor, and for example, if experience here in the Philippines, if we are not allowed to accept delivery at home. So it is required those pregnant mother to advise in the healthcare facilities. So if they go to the healthcare facilities or the midwife are trained. Okay, those midwife in the healthcare facilities are trained with PIMO. They can give a basic emergency in collaboration with OB/GYN.
Okay, it means that we have to collaborate with the doctor.
Yes.
Obstetric, yes. If we have a pregnant woman with eclampsia.
Yes, and they refer immediately to the hospital for emergency case.
Okay. We should has to go to hospital immediately if we got the preeclampsia woman. Miss Nella, do you understand, or maybe you want to ask more?
Okay. Oh yeah, Miss. I want to talk about if we deliver patient to hospital, if we need to give maybe medical treatment, because we know that give no treatment or delivery patient from our facility to hospital, sometimes we overthinking. So it's okay or not like that.
Can we give a medical treatment to the pregnant woman?
Actually, if they are in the healthcare facilities, what we did of the midwife first is give the fluid infusions or IV infusions. Since, as I mentioned, that the midwife in the healthcare facility are trained basic they are BMOC trained. So they are work hand in hand with the doctor. Even the doctor can advise, or you give dexamethasone or for the lung maturity of the babies, because if it is severe, it leads to sometimes we cannot control, and the management is to deliver the baby. So the initial action is to give for dexamethasones to to give the baby a lung maturity, and then some antihypertensive drugs. Okay, that is initial actions of a midwife, but it is work hand in hand with OB/GYN. It is the conditions of the patient is referred to the OB/GYN, and then the OB/GYN give instructions to the midwife.
Okay, for the first aid is giving a dexamethasone. Until we,
Antihypertensive, and then
yes.
after, if the doctor's advice, give the, because the imminent delivery occurs, so they give dexamethasones for the lung maturity of the baby, if the conditions or if the baby is premature.
Okay, if the condition is premature and it has to be prescription from the doctor to give the dexamethasone, we cannot give it by our as a midwife.
Because
Okay.
under the law of midwifery, we are not allowed to give medicines, because we only accept is a low risk.
Okay, because of the law, Bu Nela. Ya, karena peraturannya tidak boleh begitu. Okay, maybe any question, or we are going to the next question. Thank you, Mrs. Marilo. Okay, for the next question is for Mr. Azran. Do you hear me, Mr. Azran? Mr. Azran?
Yes.
Okay. You have 3 questions. We begin to the first question first. If someone has a cardiovascular disease, especially heart failure, and they want to do activities or exercise after treatment in hospital, what things do we need to convey to prevent risk factors? From Miss Felicia.
All right. Should I answer the question one by one, or should
one by one? Or maybe you want to all
all right. If someone
answer it.
If someone has a cardiovascular disease, especially heart failure, and they want to do activities or exercise after treatment in hospital, so what things do we need to convey to prevent risk factor? What we do basically, we look at the baseline of we do look at the patient baseline. We do the assessment. We look at the patient condition, especially we look at the, usually for heart failure, for example, like heart failure, we look at the what categories of heart failure, because we know that heart failure is there's a stages which is under New York Heart Association classification, class 1, class 2, class 3, class 4. So like class 1, we still can do the normal activity. What we do is we use the baseline functional capacity. For example, we conducting the 6-minute walking test, and we look at the how far that patient be able to do it. You know, for example, like we do twice. That's the what they call it, American Thoracic Society's guideline. We have to conduct the 6-minute walking test. The first test, after the first test, and then we rest the patient, and then we conduct the second test. So we look at the distance, how long, you know, how many meters patient be able to walk. So that's number 1. So that's considered baseline, and then we prescribe the exercise based on weight. So other than that, the functional capacity, we look at the normal functional capacity, which is sit to stand test. So we conducting the 30-second sit to stand test, and then we look at how many times repetition that patient be able to do it. And then, as we know that the heart failure patient, nothing that we can do, because this patient, we know that end of the day, nothing that, you know, like for example, like coronary artery disease, something that we can do with this patient, because of we try, you know, like try to regain the functional, you know, their fitness back. But for heart failure, just normal and maintain their functional activities. So and then we will discuss this thing with the heart failure team as well. For example, like the cardiology, and then basically we need to endorsement from the cardiology before we do exercise with this patient. because these patients mainly under cardiology supervision, they will restrict this patient to do and don'ts, basically what they can do and what they can't do. So as I mentioned, if patient required to do exercise, and then we start doing the baseline assessment. So from baseline assessment, we prescribe an exercise and we try to progress just to maintain patient active daily living. So I answer the question?
Miss
So
Felicia.
yeah. So basically, in the management of heart failure, like what happened in IJN, if the patient category under category NYHA class 4, so this patient basically the ejection fractions below than 30% or 25%. So ejection fraction. So this patient actually is candidate for heart transplant or bridge to transplant, which is we will put the heart device. So for this patient until this patient receive receive the heart. Okay. So am I answer the question about that?
Okay,
Okay,
Miss
Mr. Azran.
Felicia.
I want to know, before that, thank you for your explanation. And then I want to know about maybe, do you have any recommendation for assessment tool to determine the ability of the heart failure patient to carry out the activity? Because we know that you have many experiences about the heart failure research before. Thank you.
Yeah, sure. I think, like heart failure management compare than the artery disease or other cases is slightly different because of we have to work together closely with the cardiologists because of all these cases is very prone to, is look at the patient condition as well. That's why I said we have to do assessment. If a general heart failure patient, we still do rehab like a walking exercise, and then we don't force patient to do like high intensity exercise because we don't know how much the heart can cope with the intensity. So that's why we need to find what are the baseline of the patient. Basically what we do is a functional capacity, and then because of the heart failure, we need to know the classification as well. So if patient classification like class 1 or class 2, so patient be able to do a lot of activity compared than class 3 and class 4, because patient may with some drug which is will affect or impair their performance during the exercise. All right. So like what happened in IJN, we do activities, we do cardiac rehab, but not for the heart failure patient. So the heart failure patient, we have a special interest group, which is their team involved with the heart failure nurse, cardiologist, which is the heart failure team, and also the physiotherapist in heart failure. So they're more focusing on patient quality of life. So that's it. Yeah. Compare than heart valve replacement, coronary artery bypass graft, post PCI, that we have a special program for that. So the heart failure team, they has a specific, which is basically their aim or their goal just to maintain patient active daily living. All right.
Okay, thank you so much, Mr. Azran.
Okay. I think that Miss Felicia understand what you explained about it. Mister, we are going to the next question.
All right.
Okay, how do we determine the right exercise for cardiovascular cases after surgery?
Okay, so
from Miss Ragil.
Okay, so let me answer this question. So how we determine the right exercise for cardiovascular cases? So there's a lot of there's so many guidelines that we can follow. So like in IJN, we adopted the guideline of exercise from British Association Cardiac Rehabilitation Guidelines, and also combination with American Heart Association guideline, because in Asia we don't have special guideline for Asian population. So that's why in IJN we get it from Australia, from British, and also from American. So we try to combine, and then we look into what are the best exercise guideline for our patient. So like post-surgical patient, basically we look at the wound. For example, like post-sternotomy, yeah, post-ABG patient, post-cabbage, for example. So we do assessment like now we do which is the upper upper limb exercise prescription. So we use that as a assessment, and then from there we will know that how much intensity, how much load that patient be able to lift. And also we do the JAMA hand grip to look at the patient's strength, especially for upper body strength. And then other than that, apart from the strength activities, and then we look at the functional capacity like 6-minute walking test. If patient required to do a CPAT test, which is cardiopulmonary exercise testing or graded exercise test, we will conduct that. But the graded exercise test basically is endorsed by the cardiothoracic surgeon or cardiology. Like the normal surgery, normal assessment is conducted by a physiotherapy team. And then that's the thing. How we prescribe, we do 6-minute walking test, but we don't conduct the high intensity exercise testing, which is the stress test is too vigorous for the post-surgical patient. So we do 6-minute walking test, JAMA hand grip, and ULEX test, upper UULEX. So based on it, we design individualized exercise prescription that I mentioned in our slide just now, which is 40 to 80% heart rate reserve. We use the Covenant formula to calculate that. It's based on patient age, and then we calculate based on the minimum is 40 and maximum is 80%. And then now the new program, what we do is we staggered that, which is 40 to 50%, 50 to 60%, 70 to 80%. So we call it progressive, moderate, high intensity. So it gives room to the patient based on the assessment, and then we gradually progress from low intensity, moderate to high. So we don't simply exercise the patient, which is with a high intensity. Yeah. So unless we do have the CPAT, which is cardiopulmonary exercise testing result. With that result, we can identify which intensity is the best for that patient. All right. And at the same time, we look at the RPE, rate perceived ejection scale, which is from the box scale. And then we make sure that patient not
I
exceed.
beg your pardon, Mr. Asran, because our time is limited.
Okay.
Maybe we're going to the last
question.
Is okay? It's okay.
What is the last question?
Yeah.
What we suggest for patients with heart failure to exercise regularly every day? Walking exercise is the best. So we encourage our patients to do walking. So for example, like I mentioned earlier, we do 6-minute walking test, and within 6 minutes, patient be able to do, for example, the patient be able to do 250. That's considered their baseline. So every day we progress patient like a 10% add on from 250 meters. So walking exercise is the best. Make sure that patient exercise, especially for heart failure patient, don't let them exercise in the hot weather, sunny days, which is make sure okay in the morning, and then they can do BD, which is morning once, and afternoon, which is evening once, or if they be able to do it. And then we try to use the RPE as indicator of how hard is the exercise. So they can do it walking exercise. I think is sufficient for them, especially for heart patient, for heart failure patient. For post CABG patient or post intervention, they can do more than that. So same exercise, we encourage them to walk, which is walking exercise is cheaper, and then no need to invest for treadmill or stationary bike. So they can practice that at home. All right. Thank you very much.
Thank you, Mr. Asran. Okay, as a moderator, I think that it is the finish of the discussion. I would like to conclude what we have to in the first session. Okay, from the first is from Mr. Derek. There are some questions about the hypertension treatment, such as opioid, in the HES patient, if the opiate is not available, they should give an alternative anesthesia and also can use a morphine. And for the question about the complication that take drug every day for life, they should think about the modification diet and exercise. It's okay to take it every day. And then for the cardiovascular pharmacology, focus on the fundamental mechanism of cardiovascular cells and how drugs influence the heart and vascular system. And from the information for the patient is one of the important things to manage the cardiovascular disease. As patient and family-centered care, we need to give education about QOL, quality of life, prognosis, risk of death despite ongoing active treatment, goals and efficacy of therapeutic plans, hospice or end-of-life care in visas. For the preeclampsia patient, bed rest is one of the most important principles of care. Rest in left lateral position to promote blood supply to the placenta and the fetus. And the last, not only are more elderly patients surviving from cardiac events, but because patients are less likely nowadays to be referred to cardiac rehabilitation. Okay, thank you for being our speaker, Mr. Derek, Mrs. C, Mrs. Emilio Marilo, and also Mr. Azran. Thank you so much for being our speaker in this special occasion. We are going to go back to the Master of Ceremony.
Session 1 finished. Thank you, Ms. Made. There are so much valuable knowledge that we might learn from the discussion. And maybe the committee have something to show. Yeah, once again, we will say thank you for all the speakers bringing us to a very productive session for today. And we can give applause for them. Okay, thank you. We jump to the next agenda is the second conference and discussion, which will be guided by our moderator, Miss Dani Putri. And let me read the short bio of Miss Dani. Okay, her name is Nurse Dani Putri Sulistianingrum, MCAP SPCAP MB. She graduated in master degree at Indonesia University. One of the research that she has been conducting is in the effect of using fluid balance application on interdialytic weight gain in the stage 5 chronic kidney disease patient undergoing hemodialysis. She has participated in many seminars and workshops, as you can see, and she also has so many experience as a writer in online newspaper with the topic Mengenal Lebih Jauh Benigna Prostate Hypertrophy. Ladies and gentlemen, let us welcome our moderator, Miss Dani Putri. And the next session is fully moderated by Miss Dani for approximately 90 minutes. Hello, good morning, Mrs. Dani. How are you?
Good morning, Miss Linda.
Okay, the time is yours.
Thank you. Good morning, ladies and gentlemen. I am Dani Putri Sulistianingrum. You can call me Dani. I will guide this second session. The Honorable Lecturers, Mianti Nuriski Sutejo, Sarjana Fisioterapi, Magister Public Health, Nurse Kristianto Dwi Nugroho, Magister Keperawatan, Nurse Resa Nirmala Jona, Magister Keperawatan, Apoteker Francisca Gloria, Magister Farmasi, Komaria, Sarjana Sains Terapan, Magister Kesehatan, and all of my beloved friends. First of all, Let us thanks to Allah Subhanahu wa Ta'ala, because His blessing we are able to come here to join in international conference. Ladies and gentlemen, the presentation today is about prevention, detection, and treatment of cardiovascular disorder. Now, I will read one by one our agenda today that are: first session is Miss Mianti, the second session Nurse Kristianto, the third session Nurse Resa Nirmalajona, the fourth session Apotheker Gloria, and the last session is Komaria. Well, ladies and gentlemen, let's open our meeting by saying Basmalah together. Bismillahirrahmanirrahim. Thank you. For the next agenda, is presentation session. Please welcome Miss Mianti, Nurse Kristianto, Nurse Resa Nirmalajona, Miss Gloria, and Miss Komaria. Please welcome. Okay, please give applause to them. Hello, good morning. How are you today? Yeah. Get to meet you all. We have about prevention, detection, and treatment of cardiovascular disorder. What about your presentation, Miss Mianti?
Okay, thank you, Miss Dani. For my material today is about how is management physiotherapy about post-operative coronary artery bypass grafting, and explain two doses about exercise for this condition.
Oh, about exercise.
Yes.
Okay, I will read curriculum vitae of Miss Mianti. She is from physiotherapy department. She was graduated for Magister of Public Health at Gajah Mada University 2020. She was a private tutor and now has joined with Stikes Logorjo since 2021. Okay, we give 15 minutes for your presentation. Without further ado, the time is yours.
Okay, thank you for your time, Ms. Dani. Okay, today we will to sharing about management physiotherapy. Yes, post-operative coronary artery bypass grafting for the cardiac heart disease. Okay. Oh, I'm sorry. Okay, for an objective, first to know the etiology of coronary heart disease, and then to know the description coronary artery bypass grafting for the cases coronary heart disease, and then to know the management post-operative for the patient post-operative CABG, and then to know the appropriate doses for exercise. Okay, coronary heart disease. Okay, for definition, okay, this disturbance function heart causes excision stenosis facial blood coronary because deposition pliqui arteriosclerotic, so that can influence one or a number of artery. One cases, this patient experience triple facial where there is stenosis more than 50 until 70% on part big branch main from facial blood heart. Okay, for the prevalent case heart coronary, The World Health Organization states that coronary heart disease is a heart problem in the cardiovascular system. The number increased rapidly with a death rate of the 6.7 million cases. And the 2020 North Africa and the Middle East, Central and South Asia, and Eastern Europe had the highest prevalent rate of CHD in the world. And in 2020, CHD mortality rate whereas 112.37 to 100,000. Coronary heart disease mortality rate were highest in North Africa and the Middle East, Eastern Europe, and Central Asia. Okay, we can see for the prevalence of heart disease in Indonesia. For the reference in Indonesia, yes, have the point 1.5% for the reference, and the lowest of the efforts in the for the cases heart disease is Nusa Tenggara for the 0.7%, and the highest for the prevalent heart disease with efferent is 2.2 for the West Kalimantan. Results from the Riskesdas 2018. Okay, for the etiology, there is narrowing all blockage for abnormality of the coronary arteries. The blockage of this blood vessel can stop blood flow to the heart muscle, which of often characterizing by pain. In several conditions, their heart ability to pump blood can be lost. Okay, for the pathophysiology, coronary heart disease is caused by blockage of the blood vessel that supply blood to the heart muscle. The heart muscle also needs blood to move its muscles so that they are still able to pump blood throughout the body. Meanwhile, atherosclerosis is the build-up of plaque in the arteries leading to the heart. The plaque contain excess for the cholesterol, calcium, or another material in the bloodstream. If they continue to accumulate, this plaque with clot or the blood vessel. If the thrombocyte and atherosclerosis for the occur, the blood is the heart muscle will be reduced. Lack of the blood to heart can cause various serious illness, such as angina pectoralis and the heart infarct, which causes sudden death. And this is for the sign and symptom for the casus cardiac heart disease. Yes, it's the chest pain, feeling of pleasure in the chest area, chest feel heavy, nausea or pain in the pit of the stomach, and last the cold dry. Okay, this is management of patient with coronary heart disease. Most patients with this condition are recommended to perform cardiac revascularizing. The action that is usually performed is coronary artery bypass grafting and the heart ring replacement, depending on the patient condition. Okay, CABG surgery is one of the interventional treatment from the CHD by creating a new channel through the coronary artery are the experiencing narrowing or blockage. Okay, coronary artery bypass grafting has the goals of the overcoming obstruction of the coronary artery channel due to narrowing and even blockage of the heart muscle. And next, for the goals of the operation CIBG, yes, to reduce the for reduce the symptom of coronary artery disease so that patient can lead a normal life and reduce the risk of heart attack or another heart problems. And for the complication from CIBG surgery, as a decreased cardiac output caused by post-operative bradycardia and the tachycardia and the arrhythmias often occur 24 until 36 hours. And then post-operative hypertension or hypotension surgery, and then post-operative bleeding, and then wound infection, and the last neurological dysfunction. Okay, next. Management physiotherapy can give to patient with post-op CIBG condition as the chest exercise or chest physiotherapy and the active and passive exercise. Yes, this condition can.
I'm sorry, Miss Mia, you have 3 minutes.
Okay, this condition can be give surgery within 24 until 36 hours or according to patient condition. By first examination, the patient level of thickness, pain, and mobility. Okay, for the assessment physiotherapy, for the measurement of painful, we can use a numeric pain rating scale with the categories 0 for no pain, 1 until 3 for painful light, and 4 until 6 for painful correctly, 7 until 10 for very painful. For the measurement of apnea, yes, we can use a Burke scale. We can see for the categories Burke scale, yes, we have to measurement use ordinary scale with value from 0 to 10 based on the complaint filled by the patient. Okay, next. For the measurement activity functional, we can use Bartel, index Bartel. Yes, the functional ability of the patient cannot be dependent in carrying out activity of daily living and the patient still feel weak. With the interpretation for the index Bartel, for the point 0 until 100 for 0 dependently full, and the 100 for independent. We can see for the statement. Okay, next, for the measurement about aerobic fitness, we can use 2 minutes walking test as a simple, objective, and expensive test that can be performed in a hospital with fast and efficient time management. Okay, this test can be also performed to access functional capacity and is very useful to assessing prognosis. Okay, next. Okay, physiotherapy exercise. Okay, for the physiotherapy exercise, we can tell to patient to spirometry with fold 9. Yes, like this picture, we can see. Okay, for the purpose of the incentive spirometry, reduce the incidence of ataxiasis, reducing patient and muscle space, prevent bed rest complication and reduce heart function, prevent pulmonary complication and lifestyle hospital, and the last, increasing the volume vital capacity of lung. Okay, this is for reduce of exercise. We can see number 1. Yeah, sit on the able to comfortable and then hold the incentive spirometer in an upright position. Place the mouthpiece into your mouth and breathe in slowly and deeply as possible. You will notice yellow pistol rising toward top and the bottom column. Okay, next. Okay, it's next. I know. And then for identification and contraindication, yes, for identification for old codes, smoker, and the contraindication, traumatic injury and did. And then next for deep breathing exercise, yes, we can know the definition. And then also next for purpose of deep breathing exercise to achieve more controlling ventilation and increase maximal alveolar inflation, mass relaxation, and relief anxiety, prevent useful pattern of respiratory muscle active and slow down the frequency of breathing. Okay, next, this is the technique, yeah, about the breathing exercise. This is the indication and contraindication for breathing exercise. Okay, this is the mobilization. Mobilization causes circulation improvement, makes deep breathing and stimulation normal gastrointestinal function, encourage to move the lower leg as soon as possible, use within 6 hours. Okay, this is the indication and contraindication. For indication, muscle weak, long bed repetition, physical rehabilitation, contraindication, thrombus, traumatic, and the spinal cord injury. And then this last conclusion, some of the exercise given by pet therapists can be given in accordance with the FITT that has been agreed upon by patient or can be carried out according to the patient condition and the level of ability to perform this exercise. Avoid the exercise give the patient experience severe pain and short of breath which causes discomfort, feel the patient. Okay, the last. Thank you.
Okay, thank you, Miss Mia. Please give applause to Miss Mia. Next turn is for the second speaker, Miss Kristianto. He is from nursing department. He was graduated from Magister of Emergency Nursing at Brawijaya University 2019. He was a lecturer at Stikes Patiwaluyo, Malang from 2018 until 2021, and now he has joined with Stikes Telogorjo since 2021. Okay, Miss Kristianto, you have 15 minutes for your presentation. The floor is yours.
Okay, thank you, Ms. Dani. Assalamualaikum warahmatullahi wabarakatuh. Okay, my name is Kristianto. I will present about our presentation is about sorry, I have some trouble. Yeah, I will present about end-of-life care people with cardiovascular disorder. Okay, I will present that end-of-life care people with cardiovascular disorder. Do you know what the mean of end-of-life care? Maybe operator can click my video. This cannot play. Okay, I'm sorry. I have a trouble. Okay. End-of-life care. Caregiver to people who are near to end of life and have stopped treatment to cure or control their disease. This key point is near end of life, near of death, and cure control this disease. End of life care include physical, emotional, social, spiritual support for patient and their family. Look at this. The next key point is patient as their family. We focus not about the patient, and the modern palliative care is focused about the patient and the family. The goal of end-of-life care to control pain and the other symptoms so the patient can be as comfortable as possible. Look on the focus on the palliative care of end-of-life care, and the focus is from the symptom, not focus to recover to back. No, the focus is the symptom and make up people is comfortable as possible. End-of-life care many include palliative care, supportive care, as hospital care. That's make a one when you need it. Okay, end-of-life care for who in the interest of improving quality of life and help with symptom. Palliative care can be present unstable this choice for medication. Look at the where we give a palliative care, understand the choice to for medical treatment. The organized survive to alive around a people care the helpful to other person having a lot of general discomfort and disability very late in life. Patient with resources or for another living with serious illness, little chance to getting back to normal. That's I will underline the keyword. That's the focus of end-of-life care is people with terminal illness. He cannot back to normal or cannot back to normal life, and the focus is treatment to terminal illness and treatment to end of life, like the cases of terminal illness like cancer, heart failure, cardiovascular disease, Parkinson's disease, or something like that. We are focused about cardiovascular disease. What is the cardiovascular disease? We know that cardiovascular disease is a disease in our not only the cardio, it's already that's in our vascular. I give some example. The first is heart failure. Heart failure is the one of terminal illness. The symptom is ventricular rhythm, renal failure, sepsis, and neuropathy disorder. And the final, if the end of the heart failure is cardiac arrest. It is if we not good for treatment or for saving his life, our patient will die. And the focus in psychosocial treatment is low HRQOL. That is quality of life is so poor with the people with heart failure, distress, anxiety, depression, poor health prediction, physical disability, and social entitlement. The second is a heart transplantation. The symptoms like artery particularly with renal with primary season for renal disease and death. And the psychosocial can be in the our patient is like lower quality of life, increased need to independent and control. The third is mechanical circulation support. The symptom like interstitial stroke, gastrointestinal bleeding, if is so dangerous for our patient. And the psychosocial, like many patients conclude in the stagnant and the issue to post-mortality. Stroke, after the symptom like after injury, the major patient with the enter of the new states of the disability and implant, however, can be new remain and helpless during pilot to adjustment. And the psychosocial symptom like pure lowers quality of life, and he have a big pain in your head. And now What can health workers do? Look at this. This is a palliative care model. The focused palliative care model is four focus. The first is advanced care planning. We must a good planning to care our patient. The planning is so important because if we have good planning, the patient the quality of life will be down, and he will so sick and something like that. The secondly, as spirituality, not only in the care planning, we must improve this spirituality, because other people with end of life, we must push interest in increase the spirituality of the patient. The third is caregiver support. Caregiver support not only about like for us like health workers. Caregiver support is people with others patient, like our family, our sister, brother, or something like that. And the last is symptom relief. I am a nursing. We can work together, nursing and medicine, to give good treatment for our patient. Now, this is a conceptual model of palliative care. The first palliative care focus is life prognosis, and the traditional conceptual of palliative is only focused in life prognosis and patient will be died. But in now we give some new model of palliative care.
I'm sorry, Mr. Cristianto, you have 5 minutes.
Okay, thank you.
Again, thank you.
Okay. If the life prognosis is done and syndrome life and be increased, and we hope if after patient death, we can be a good hospice. And the future of a model of palliative care is focused in our life prognosis and symptom relief, and we can be a good hospice for our patient. Development in technology and financial led to development palliative care to extend life and improve the quality of life patient. Look that the focus is palliative care is quality of life of patient. And now, what can nurse do? Sorry, operator, can next the presentation? Okay. We have one concept of palliative care. This called if patient and family center approach. Palliative care is usually majority of the people if heart failure, and when used is so led to the illness after patient QOL and treatment already have significant dismissal. The focus outcome psychosocial and spiritual healthy regrets. Next. Okay. Core concept patient and family centered care is four focus. The first is information sharing. Healthcare provider communicate and share complete the answerable information with patient and family in the way after a meeting and useful. Patient and family require time to compress and actual improve into other efficient into and decision making. The secondly is collaboration. Collaboration are patient, family, healthcare prediction, and care leader collaboration in policy and program development, improving evacuation, in facility design, in professional education, and the research as well as a delivery of care. The third is participation. Patient and family are enabled and supported in participating in care in the decision making at the level they choose. And the last is research and dignity. A healthcare professional listen to unharnessed patient and family perspective choice, patient and family knowledge, value, belief, and calculate background and impression to the planning and the delivery to care. Okay, I will enough. Thank you, Ms. Dani.
Okay, thank you. It is very interesting. Please give applause to Ms. Cristianto, Mr. Cristianto. The third speaker is also nursing department. She was graduated from Magister of Nursing at Diponegoro University 2019. She has been a lecturer at Stikes Logorjo Semarang from 2014. And now she is the head of Diploma of Nursing. Without further ado, the time is yours. Ms. Resa Nirmalajona, you have 15 minutes. Thank you.
Okay, thank you, Miss Dani. Good morning, everyone. Okay, thank you. My name is Resa Nirmalajona. Today we learn about emergency management of heart attack. Okay, learn outcome for the topic. I hope participant understand about heart attack and participant understand how to provide first aid in cases of heart attack. Yeah, what mean of heart attack? Heart attack is a sudden blockage in blood vessels that deliver blood and oxygen to the heart muscle. Yeah, be aware of silent heart attack. Why? Studies reveal that up to 40% to 60% of heart attack are unrecognized. Yeah, heart attack can occur when resting or asleep, a sudden increase in physical activity, a sudden emotional or physical stress. Yeah, recognizing warning signs of heart attack can save people's life. Why? Yeah, these common symptoms of heart attack can chest pain. Yeah, this was for heart attack, and discomfort in the left arm. But you can have a heart attack and not feel any chest pain. Okay, this picture is location of chest pain during angina or heart attack. Any upper chest, substernal radiating to neck and jaw, substernal radiating down left arm, substernal radiating down left arm, any epigastric radiation to neck, jaw, and arm. Be careful to different epigastric pain for gastritis and heart attack. And then neck and jaw, left shoulder and down both arm, and then intrasubscapular. Yes. And less common warning signs such as abdominal pain, itching in the upper body, and explain anxiety and unusual fatigue, sleep disturbance, shortness of breath, cold sweats on clammy skin, nausea, vomiting, and lightheadedness. Yeah, this could be more dangerous. Many factors can cause a heart attack, including age, heredity, high blood pressure on hypertension, high cholesterol, obesity, diabetes, alcohol, stress, and physical activity. Okay, when an attack occurs, what to do? Okay. If the sufferer is conscious, what we do, one, loosen clothes from neck to waist. Don't give anything by mouth. Don't move the patient position. Accompany to calm the sufferer, and then immediately go to the nearest health facility. And if the sufferer is unconscious, what we do, one, check carotid pulse less than 10 seconds in the neck. Yeah. If not there, we provide compression, yeah, in the location 2 until 3 finger above the processus sipoideus. Compression by 30 times compression plus 2 birds. Yeah. And the picture below, hand position of compression. Maybe operator can help to next. Yes, thank you. The next, open the airway, lifting the patient, at the nape of his neck and pressing on his forehead. And then push his chin down. But the patient has cervical trauma. We open the airway with jaw thrust. Yes. Look at the picture. This is we can help to birth the patient. One, check breathing by holding your ear to mouth of the patient while paying attention to the movement of his chest. If there is put the dentures in the patient, clean them by tilting the patient first. Okay. We provide breathing assistance for the patient with mouth to mouth, maybe on the street, and in hospital we use the bag valve mask or BVM in the hospital. We give rescue breathing 2 times and we repeat for 5 cycles and 30 time compression plus 2 breaths for the patient. Oxygen therapy, the efficiency of artificial respiration can be greatly increased by the simultaneous use of the oxygen therapy for patient. Mouth-to-mouth provides around 16% oxygen. Pocket mask with an oxygen flow provides 40% oxygen, and BVM or mechanical respirator provide 99% oxygen. Yeah. And then we use a defibrillator for cardiac arrest. This is the picture. In cases of cardiac arrest, a defibrillator will save life. And this equipment has been designed in a way that virtually anyone can use to help save the life of a person who suffer a sudden cardiac arrest. Yes. AED is now available in public places. Yeah, it's very safe and easy to use. Okay. In conclusion, when we find someone with a heart attack, don't panic and call for help and provide immediately assistance first. Yeah. I think enough for emergency management for heart attack. Thank you for attention. I come back to moderator.
Okay, thank you for your presentation. It is very applicable. Please give applause to Miss Reza. Next presentation is from Pharmacy Department. Hello, Miss Gloria.
Hello, Miss Danny.
What about your presentation?
Today I will discuss about CMA, cost minimization analysis of antihypertension therapy.
Okay, about drug. Yes.
Drugs and costs.
Okay, I will read curriculum vitae of Miss Gloria. She was graduated from Magister of Pharmacy at Airlangga University 2020. She has experiences as pharmacist and she has been a lecturer until now. Many publication, workshop, and training were attended by her. Okay, without further ado, the time is yours, Miss Gloria. You have 15 minutes, okay?
Okay, thank you, Miss Danny. Good morning, all participants of ICHPR. At this moment, I will elaborate the material about cost minimization analysis of antihypertension therapy. This is the field of pharmacoeconomics in pharmacy. Next, please. We know that hypertension or elevated blood pressure is a serious medical condition that significantly increases the risk of heart, brain, kidney, and other disease. In global estimate, there are about 1.28 billion adults aged 30 until 79 years, and it happened in low and middle income countries. It can be estimated there are 46% of people who do not have any concern with their medical condition that actually suffer from hypertension. We can see data from World Health Organization in 2018, 1 of 5 women is not aware, and 1 of 4 men is the same too. Therefore, hypertension is often called as silent killer because it cannot be felt directly and the person may not be aware and thoughtful with this condition. Next. Prevalent data of hypertension globally according World Health Organization in 2019 increases until 22%. We can see in some continents are more 20%. Next. Prevalent data of hypertension in Indonesia according Riskesdas in 2018 based on the measurement toward citizens with age above 18 reaches 34%. We can see from 2007 reached 25.8%, and in 2013 it's reached 31.2%. And in 2018, the highest prevalent data is the province in South Kalimantan. It is not as the highest for 44.1%. Next. If it is observed from the data of citizen demography, with its more than or same with 18 in Indonesia, according to Riskesdas 2018. From its, we can see in population its increase from 13.2% until 69.5%. And if we see from gender, is dominated from the woman, which is 36 until 36.9%. And if we see from the region, between people who live in rural and in the city, it's 34.4% and 33.7%. Next. The high percentage of hypertension made the country, especially its government, to pay more attention on the welfare and health of its people. A country must have the goal to make effort for people's well-being and continue the development of infrastructure for better changes. The development of continuous change is recognized as Sustainable Development Goals, or SDGs. The SDGs, also known as the Global Goals, aim to transform our world. They are a call to action to end poverty and inequality, protect the planet, and ensure that all people enjoy health, justice, and prosperity. So it is critical that no one is left behind. Health is a part of SDGs, and however, health is not the only one. There are 17 acts or changes that must be done, such as to end poverty, improve the quality of education, maintain equal gender, provide clean water and proper sanitation, and peace and the fairness, along with building partnership to achieving the goals. Next. One of X in SDG is the increasing and equalizing the health of people. So its country tries to make change in health field. A country is responsible for the well-being and health of its people. For example, the improvement in health service to be fast in response, the improvement in sufficient health facilities, and the improvement in human resource. All of them are for achieving the universal health. Next. UHC, or universal health coverage, means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardships. It covers the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Next. Access to affordable, quality primary healthcare is the cornerstone of UHC, but many people around the world still struggle to fulfill their basic healthcare needs. Mental health, often overlooked, is also an important element of UHC, as it is critical to people's ability to lead a productive life. And to make health for all a reality, all people must have access to high-quality services for their health and the health of their families and communities. To do so, skilled health workers providing quality, people-centered care, and policymakers committed to investing in universal health coverage are essential. Next. So, the state, in this case the government and the private sector, has the responsibility for the welfare of public health. Besides a good health service, sufficient health facilities, supply needs of medicine and medical costs are the important factors to be noticed. And the government, organization, and industry routinely make decisions about the value of pharmaceuticals. Drug costs incur and benefits obtained by the patient. And in pharmacy, it is not only about medicine or drugs, but it's also about costs. There is a relationship between medical fee and the health outcome, which the goal is to improve the patient's life quality. This development of field is known as pharmacoeconomics. Next. Pharmacoeconomics is the field of study that evaluates the behavior or welfare of individuals, firms, and markets relevant to the use of pharmaceutical products, services, and programs. So pharmacoeconomics could help pharmaceutical policymakers to optimize the allocation of their resources successfully. It could help to provide a better understanding of the value of medicines through analysis of their costs, as well as their consequences. Using the results of pharmacoeconomics, policymaker can understand the value added to the society by using pharmaceutical. Next. So, what is the connection between pharmacy with economic and other fields? From this illustration, we may see that pharmacoeconomic.
I'm sorry, Miss Gloria, you have 5 minutes again.
Okay, thank you, Ms. Dani. From this illustration, we may see that pharmacoeconomic is a part between pharmacy related clinical or humanistic outcomes research and a part of healthcare economics. Pharmacoeconomics overlaps with both healthcare economics and pharmacy-related clinical or humanistic outcomes research. Healthcare economics encompasses a broad range of topics, including supply and demand for healthcare resources, the effects of healthcare insurance and manpower supply. And clinical or humanistic outcomes research is defined as the attempt to identify, measure, and evaluate the end results of healthcare services. Next. In the field of pharmacoeconomy, there are evaluations or methods such as CMA, CEA, CBA, CUA, COI, and BIA. Next. And in the field of pharmacoeconomy, there are some points of view perspective of payment, such as medical insurance. And there are 4 kinds of type costs, such as direct costs, indirect costs, total costs, and intangible costs. Next. Now we will discuss simple method about CMA. Because CMA focus on the same outcome or equivalent. From the illustration, we can see cost is compared with the product or pharma service to get a result or have medical outcome with minimum cost, such as the decreasement of blood pressure and sugar blood level after medication and etc. Next. And in pharmacoeconomy, especially in CMA, there are advantages and disadvantages. For advantage, the simplest to conduct because the outcomes are assumed to be equivalent. And disadvantages, CMA cannot be used when outcomes of intervention are different. Next. This is result 1. Discuss about CMA of diuretic medicine to reduce the occurring of cardiovascular toward elder patient with systolic hypertension in the elderly program. The cost is estimated based on entity number needed of treat of patients for 5 years to prevent 1 adverse event with cardiovascular disease. Next. According to the ICHPR treatment protocol, the step care was classified into 4 types of drug treatment which use photosis. Next. This result suggests that clinicians should consider using diuretics plus low-dose reserpine or atenolol as first-line therapy in patients with isolated systolic hypertension who are greater than 60 years old when there are no contraindications among this patient. Next, the second research of CMA discuss about CMA between the cost of generic medicine with innovative medicine. The medicine of antihypertension that is used is HCT, amlodipine, losartan, enalapril, and atenolol. Next, the available data show price of generic formulation are found to be less than all of their innovator counterpart formulation for selected antihypertensive drugs. Next, the third model, the third research of the CMA about cardiac revascularization in 12 healthcare based on Euro, CMR, or SPINS registries. The objective of this research is to compare the cost between CMR plus X-ray coronary angiography and FFR and CMR plus CXA without FFR. Next, the result indicated that the 12 healthcare system studied the CMR plus CXA strategy was consistently less costly than a hypothetical invasive CXA plus FFR strategy for CAD management. Next, these are the references for the materials. Okay, this is the end of my presentation. Thank you, Ms. Dani.
Okay, thank you, Miss Gloria. Please give applause to Miss Gloria. Last presentation is from Midwifery Department. So, hello, Miss Komaria.
Hello, Miss Dani.
Okay, are you ready?
Ready.
Okay, I will read curriculum vitae of Miss Komaria. She was graduated from Magister of Health Science at University Negeri Semarang. She has been a lecturer at Stikes Logorjo since 2012 until now. She already has 15 publications from 2017. Okay, you have 15 minutes for your presentation.
Yes, thank you, Miss Dani. Good morning, all. I want to explain about preeclampsia midwifery assessment. Preeclampsia midwifery assessment, the role of the midwifery in handling preeclampsia and eclampsia, continuum of care, the role of the midwife in pregnant time, the role of the midwife in labor period, the role of the midwife in neonatal period. Definition of maternal emergencies is a life-threatening situation that occur in obstruction of midwife practice that is an unexpected, delivered very quickly in relatively rare, but is often fatal for the mother and baby. This condition can appear at any time during a person's maternity cycle. Time lapse on maternal death, complication, hemorrhage, antepartum 12 hours, postpartum 2 hours, rupture uterus 1 day, eclampsia 2 days, obstructed labor 3 days, infection 6 days. Pregnant preeclampsia screening, anamnesis, identify risk factor for preeclampsia, physical examination to predict the probability of occurrent preeclampsia body mass index, mean arterial pressure, rollover test can be continued another check support, such as Doppler ultrasound to see the resistance of your uterine arteries. Labor, monitor blood pressure, monitor fluid balance, eclampsia prophylaxis magnesium sulfate, seizure control, intensive peripartum monitoring partograph, respiratory monitoring, lab test, hematology and biochemistry, psychological support, and information about preeclampsia disaster. In preeclampsia or eclampsia patient, pay attention to the ABC basic principle, airway, breathing, and circulation. Postpartum, continue blood pressure medication until hypertension is resolved. Postpartum evaluation up to 10 days and minor delegate observation and care to person who do not have the proper qualification. Give psychological support and accompany the mother during the lactation process. Documentation of post-preeclampsia maternal health to rule out chronic hypertension. When an emergency occurs, stay calm, don't panic, don't leave mom alone. Shout for please. If the mother is unconscious, assess ABC. If shock is suspended, put mother in position, resuscitate immediately, invite mom to talk and help calm mom while doing a quick check. The team approach in handling emergency case, first person, quick check awareness, hemodynamic circulation, start with fundus, coordinator, initial management, second person, first person assistant, initial management according to first person direction, ensure the readiness of emergency stroller, take the emergency stroller to the emergency location, documentation. The third person, circulation, communication, second person assistant, and documentation. Develop of preeclampsia during pregnant, first trimester, preeclampsia begin to develop. Second trimester, preeclampsia symptom arise. Third trimester, preeclampsia birth due to preeclampsia, preeclampsia screening, absent or delayed onset of the preeclampsia. Other supporting examination, check urine level with a 24-hour urine dip test or urine protein. Classification of hypertension in pregnant, chronic hypertension, hypertension before 20 weeks of gestation, superimposed preeclampsia, chronic hypertension, proteinuria, and another sick of preeclampsia. Preeclampsia complication, uteroplacental ischemia, arterioral spasm, seizure and coma, improper handling. Prediction, more often on primigravida. The risk increase on less placenta mass, gemely, trophoblastic disease, diabetes mellitus, rhesus isoimmunization, hereditary factor, vascular problem. Prevention, reduction of calorie flood and a low salt diet does not prevent hypertension. Pregnant can even hurt the fetus the benefit of aspirin and calcium with a doctor recommendation, early detection, and prompt treatment. Principle of preeclampsia rescue, preeclampsia, nutrition, infection, and genetic, pregnant screening and management, preeclampsia screening, optimization of maternal and fetal condition, termination of pregnant, optimization of perinatal service. Post-preeclampsia, short-term impact, medium, long in mother and baby. Next, pregnant readiness. Preeclampsia management, refer immediately. Pre-referral stabilization, stress reduction, mother and family counseling, antihypertensive therapy, convulsion, prophylaxis with magnesium sulfate. Labor management, delivery in hospital, severe preeclampsia, delivery within 24 hours, eclampsia, delivery within 12 hours. Postpartum care, magnesium sulfate is continued until 24 hours postpartum. Antihypertensive, monitoring the amount of urine. Referral success, good communication with referral center to the ensure place available, appropriate stabilization before referring, vehicle that equipped, complete, and working fine, properly trained nurse is a must accompany neonates. Thank you. I will give it back to moderator, Miss Dani.
Okay, thank you for your presentation, Miss Komaria. Please give applause to Miss Komaria. Okay, thank you for all the presenters. Well, ladies and gentlemen, now we are in the opinions, questions, and answers session. Please raise your hand or write in the chat room. Don't forget to mention your name. Okay, Miss Mianti, you have a question. I would like to ask what appropriate dose of exercise for patient post-op coronary artery. Please, you may answer. Thank you.
Okay, thank you, Miss Dani. For the appropriate dose for the exercise to patient post-operative coronary artery bypass grafting is first time we can look from the patient condition first, and then we can give the exercise like for the lower and the middle and to highest. And then for the doses, we can look from FETT or frequency, intensity, time, and type. This is for doses exercise we can give for look FEITT. For another exercise like chest exercise or breathing exercise or mobilization exercise, that it must be focused from frequency, intensity, type, and time. Okay, thank you, Miss Dani.
Okay, so you look condition patient. Okay. And then, okay, Mr. Cristianto, you have a question. As a family with cardiovascular disorder cases, would should family to according family-centered care?
Okay, thank you, Miss Dani.
Yes.
We will talk about concept patient and family centered care. That is improve our involvement, the family and the patient to focusly in the family in the treatment or the care. The focus if we open the concept of patient and family centered care, the focus is collaboration. Collaboration not only about the nurse and the medicine, the nurse and the pharmacy, not about that, but the health workers and the patient, health workers and the family. That we a family can give treatment or can give care to our patient. That's this mean as collaboration. And the next concept of patient and family centered care is participation. Participation not only about the patient participate, the family participate to care, not only that, but the family can take care, the family can make a decision, the family can give an opinion to health worker, to nurse, what must health worker do to the patient. That's as the main is involvement the family. I think that's all. Thank you.
Okay, we must focus to patient and family.
Yes.
To increase quality of life
Yes.
patient.
Yes,
Okay.
of course.
Thank you, Mr. Cristianto.
Yes.
And then, do you have any question? Okay, Miss Reza, you have a question. If we find cardiac arrest at home, what can do for emergency management at home? Please, you may answer.
Okay, thank you, Miss Dani. We find cardiac arrest at home. What we do first, don't panic, and we the patient provide give the patient for we have to make sure the patient is conscious on are conscious. If a patient conscious, we have what we do. Loosen clothes from neck to waist. Don't give anything by mouth. Don't move the patient position, and call for help to ambulance in to hospital transfer. And if the patient unconscious, the first we check carotid pulse less than 10 seconds. If not, their carotid pulse, we provide compression. Location is 2 until 3 finger above processus sipoideus, 30 time compression, and we do open airway. For to breathing patient. The open airway by lifting the patient at the nape of his neck and pressing on his forehead, push his chin down. And we check breathing, the holding your ear, the mode the patient while paying attention the movement his chest. If there food danger in the patient, clean them by tickling patient first. And we give the patient birth mouth to mouth or use mouth to mouth. Yeah, and these cases in the home, yes. Jadi so we can birth the patient mouth to mouth. I think enough for the answer. Yes.
Okay, thank you, Miss Reza. The first, we must don't panic.
Yes.
And then we check breathing and carotid
Yeah,
pulse.
cardiac pulse. Yeah.
Okay. Thank you, Miss Reza. Miss Glory, you have any question? You have a question. As we know, cost management is one of important thing to do on patient with cardiovascular disorder. What should we educate to a health professional about cost management of antihypertensive therapy? Okay, please you may answer.
Okay, thanks, Miss Danny. So if we focus on CMA, it discuss or talks about the same equivalent or outcomes clinics with minimal costs. So we can see, we can comparing medication that are the same chemical entity or the same dose, like brand or generic versus generic with other company. We see what is the minimal cost and equivalent outcome clinics, and what we should do communication with doctor. We can tell them, of course, with evidence base. We can show the journal or the research about this compare cost and outcome clinics. Maybe that's it, Ms. Danny.
Okay, thank you, Miss Gloria. Do you have any question? Enough? Okay. Miss Komaria, you have a question. There are a lot of number preeclampsia cases in Indonesia. It is caused pregnant woman death. What kind of risk factor of preeclampsia? Okay.
Yes, thank you, Miss Dani. Risk factor of preeclampsia. I think in Indonesia, risk factor of preeclampsia, obese woman, because obese woman, it will be more heavier to heal pap blood. The second, first pregnant because they do not educate will about screening pregnant. And then as midwifery, we can advise patient to always have pregnant check to prevent or reduce preeclampsia complication if there are factors. I think enough. Thank you, Ms. Danny.
Okay, thank you. Do you have any question again? I think enough. Okay, maybe 5 questions are enough for now. Well, ladies and gentlemen, finally we are in the last agenda. We would like to say thank you again for the presenters and all of the audience for active participation. The conclusion of presentation today is physiotherapy management of post-op coronary artery bypass grafting. Some of the exercise given by the therapist can be given in accordance with the FITT that has been agreed upon by the patient or can be carried out according to the patient condition and level of ability to perform this exercise. And number 2, end of life care of people with cardiovascular disorder, care given to people who are near the end of life and have stopped treatment to cure or control their disease. End of life care include physical, emotional, social, and spiritual support for patients and their families. Okay. Hopefully the presentation will give benefit for us. Thank you for your attention. See you next time. Have a good day. Thank you. Come back to Miss Linda.
Yeah. Okay. Thank you so much, Miss Dani, for bringing us to a very productive session for today.
Okay. Thank
And
you,
the
Miss
committee,
Linda.
yeah, thank you, Ma'am Dani. And the committee will share to you about thank you note. So we're just waiting. Yeah. Once again, thank you for all speakers. So many knowledge you share to us. Please give applause once again. Then I'd like to give announcement for the past participant now. If we already share the presentation link, so just check and fill the form. And don't forget to check again your name. Thank you. And finally, the conference session has ended. We will rest for 1 hour before we continue the oral presentation at 1 p.m. And I really hope that all participants can also join and listen to the oral presentation. Thank you.